So remediate just is where you go back and review concepts. So it doesn't require you don't have to write anything down. You don't have to do anything. The only thing I'm looking at is, did you take the time to remediate? Now, if you missed more than half the questions and you took 1 minute to remediate, you probably didn't review all the concepts you missed. So that's kind of where remediation comes in. So yeah, so long as you review it, and I look at the time and how many questions did they miss. Now, when they do a remediation, it will remediate all the questions. So yes, so back to the practice quiz. Sorry, I confused you guys yesterday. The practice respondents quiz with monitoring is in fundamentals. So it's in week 2. Yes, Mercedes. Now, Mercedes, do you like to go by Mercedes or Mercy? Would you prefer I call you Mercy? I noticed that on your emails. Okay. So 63% or better will, in theory, get you full points. However, I will look at if you remediate. And if you don't go back and remediate, I might take a little bit off because you know, it's not going to help you to do these if you don't go back and look at what did I get wrong and why did I get it wrong. So back to the practice quiz. So it is in Nursing 130. It is in lecture 2, and it's Respondus or Lockdown Practice Quiz, I believe. So make sure you have, it says student ID. I will take your driver's license. Make sure that you, because it will ask for you to put that up to the screen. Make sure that you're in a well-lit area, but not too bright. Make sure you're not wearing a hat or anything that might cover up your face. It doesn't want a password, Veronica. I think you're in the wrong quiz because I know I didn't set up a password for it. So lecture 2, if you scroll in the modules and then you go to, actually, let me share my screen with you guys. Desktop. Okay. So this is 130. I'm in the modules section. You scroll past this introduction. Here's lecture 1. And here is lecture 2. So that's the lockdown browser practice quiz. And then if you go into it, it doesn't let me take it because this is in the the faculty. But you'll just take the quiz and as you can see, I don't have it set for anything specific. So I'll stop sharing for a minute. I'm not 100% sure, Christina, probably. So I would just say yes, actually, because it is marked on there when you do that. That way I know, but that way we can make sure it really is you taking the quiz every time. So you also need to have a microphone because it's going to pick up the ambient noise. Make sure your face is visible. So you see me, you see my whole face. If I'm like this, or like this, where you just see the top of my head, that does not work, guys. It will flag. So I need to be able to see your entire face. And then that's how it's going to work. So, and I really, like I said, get those done by no later than like Thursday noon. That way, if there's any issues, I can, we can try and work things out. So far, there's been a couple that it didn't submit for, and I sent out emails. Yeah, I know. I know. And this whole startup is annoying, I know, but the problem is, and this is coming actually from the state board guys, they're very, very concerned that there's been a lot of cheating. I'm not saying that you guys are cheating. I'm just saying that there has been, and we have definitely noticed a significant uptick in some grades last term. So again, not saying that those students are cheating. Um, because I did notice a similar trend the term before that. But we just want to make sure that everything's on the up and up. You certainly don't want us to lose our state board certification because then we're kind of up a creek with the nursing program. So that's why we've had to implement this. We're not the only universities doing so. So, yeah. All right, so are we ready to get started on lecture? Today is all about communication and physical examination. I do have Kahoots again too for you guys. Yeah, everybody, and thank you, Veronica. Not necessarily Christina. So I do go back and look, and if there's anything I think is really, it tells me which ones are high priority, low priority. So I'm gonna look at high priority first, but there is a bit of leeway. And anyone who used Respondus before, if you're going, I don't need to take the practice quiz, we use it. No, every single one of you needs to go in and take that practice quiz because I need to know that your monitoring system is working prior because we have had issues with students who have used it before. So. Get that out of the way. All right. So chapter 24 is all about communication. Thank you. You know, learning how to communicate is a lifelong process. It's constantly changing. And by using therapeutic communication, you're helping to promote your own personal growth and help the patient attain their health goals. It also makes things safer for the patient if you use effective communication. So it makes you a better nurse, makes the patient safer and patient care better. So communication and interpersonal relationships. So when you communicate with people, you establish relationships, hopefully caring relationships. All of your behavior communicates, and all communication influences behavior. For instance, if we were talking face to face and you were standing there with your arms crossed and kind of looking at the ceiling and everywhere else but at me, I might take that as it disinterests. And I might be like, well, fine, that student doesn't care. I'm not wasting my time. Not that I would do that, guys, but that's how that's how your behavior can influence communication. When using interpersonal communication, you need to have the ability to relate to others. So empathy, to be able to understand where people are coming from. You also need to take the initiative to establish communication and then maintain that communication. You need to be authentic and then respond appropriately to the other person. So, communication requires what's called a sense of mutuality, which is a belief that you and your patient are equals. You have additional education that they don't have, but don't talk down to them like they're not important or that you're not on a peer level, because you are. So ways that you express caring or being sensitive, accept the expression of positive and negative feelings. Patient goes off on you, that's him expressing or her expressing their negative feelings. I'm sorry you feel that way. What can I do to make you feel better? Sometimes just listening to them vent helps. Developing those relationships, instilling faith and hope. There's a fine line with that, though, because there are times where there is not, the situation doesn't have any hope. In a patient who's terminally ill, you don't want to give them false hope. So there's a fine line there. providing a supportive environment where they feel comfortable, um, and assisting with, meeting their human needs. Also, allow for their spiritual expression. So, when you're developing communication skills, nurses who develop critical thinking skills, they actually make the best communicators. Humility is also very necessary to help you recognize when you need to better communicate and intervene with patients. You want to have a self-confident attitude because you don't want the patient to know you don't know. So basically what I'm saying is you never want to let them see you sweat. You don't want them to know that you're unsure. As student nurses and then as graduate nurses, you guys will run into those where you're like, I'm not confident. This is my first time starting an IV on a real person. Don't let the patient see that you're not confident in yourself. Okay. If you are uncertain or not comfortable, ask for help. Um, Maybe you are starting your first IV, and so bring your preceptor in with you and have them watch you to make sure you're doing it correctly. Perceptual biases, they're influenced by your culture and education. So a patient's education level may affect how they perceive things. They can interfere with accurately perceiving and interpreting messages from others. So you'll have to be aware of any biases that you have and that the patient may have. And never assume that you understand another culture. You may know some about it, but you may not know it entirely. Integrate communication skills in your process. And then emotional assessment. It's an assessment and communication technique that allows a nurse to better understand and perceive emotions of themselves and others. So it's where you assess not just your patient emotionally, but also yourself. You need to use self-awareness, motivation, empathy, and social skills to help build therapeutic relationships with patients. Sorry, let me take a drink. Levels of communication. So interpersonal communication is that self-talk. It's your inner thoughts and inner communications. They influence your perceptions, feelings, behavior, even your self-esteem. And it helps you develop a self-awareness and hopefully positive self-esteem. So when you have those thoughts to yourself, if those are negative thoughts, that's not helpful. You need to have positive thoughts. So really work with that within yourself. I can do this. I am good. I am. To give yourself that confidence. Now, interpersonal communication is one-to-one interaction between nurses and another person. So it could be a nurse and another nurse, a nurse and a doctor, a nurse and a patient. This is interpersonal communication is what's most frequently used in nursing. Then you have small group communication, interaction when a small number of people meet. Usually it's goal directed and it requires understanding of group dynamics. So conferences, what we're doing today, this is small group communication, although you guys are kind of a large group, but it is still considered small group. Public communication is interaction with an audience or a group of consumers about health-related topics. You might be presenting scholarly works to colleagues at a conference or leading classroom discussions with peers or students. So again, this is considered public. I consider this a small group because it isn't. Now, if I was talking to the entire student body, then that would be more of a public communication. And then you have electronic communication. So the use of tech can help create ongoing relationships with patients and their healthcare team. The biggest thing is you need to make sure you're using a secure messaging system in order to comply with HIPAA. So even using electronic communication, it has to be secure so that you are not violating patients' HIPAA rights. Most EMR systems, if they have a way to communicate with patients, it is secured. So before sending that email to the patient or email regarding patient information, make sure it's a secure network. All right, we're going to do a quick quiz. We just went over the levels of communication. So first, interpersonal. Which one is interpersonal communication? There's one on there we didn't review. So yes, it is B. Occurs within the individual. So occurs within yourself. Interpersonal communication. Which one is interpersonal? Fantastic. Yes, interpersonal is that one-to-one interaction. Now, here's the one I didn't discuss, but I threw it in here anyways. Transpersonal. So what we have left is interaction with an audience, interaction within a person's spiritual domain, or interactions with a small number of people. You guys are right. Yeah. So process of elimination, I guess. Interaction within a person's spiritual domain. Number 4, small group. Which one is small group? Absolutely. Interactions with a small number of people. And then the last one, public. Which one is public? Yep, absolutely C, interaction with an audience. So, next one, quick quiz. You're invited to attend the weekly unit patient care conference. The staff discusses patient care issues. This type of communication is A, public, B, intrapersonal, C, transpersonal, or D, small group. You guys are right. It is D, small group. Good job. So just a totally unrelated side note. Do y'all know have you seen the lady in that meme that I have on that slide? She's like so cleaned up herself and gotten her life together. It's so lovely to see. All right. Elements of the communication process. This is a big one. So this is what's called a circular transactional model. Obviously, you can see it's a circle. Each person is a speaker and a listener. So you are both. you're both a speaker and a listener. Right now I'm more of a speaker than a listener, but I am watching the chat as things come up. So I'm listening in that sense. And you're also simultaneously sending and receiving messages. And that's where this virtual learning gets tricky, because I'm sending a message with my voice, but you can't see me, and then I can't see you. So I can't see your body language, your facial expressions, hear your tone of voice. So this is where communication is very, very, very tricky. So first you have the referent, and that's what motivates a person to communicate with another. That's your stimulus. So the referent is your stimulus. Like, why do I need to talk to this person? Sender is the person who encodes and delivers a message, who sends the message. So it's encoded, you say it into words, and then you deliver it. The receiver receives the message and then decodes it. So what is this person trying to say? Generally, encoding and decoding is very easy, so you don't have to go through a lot of thought process. The message is your content. It's what I'm trying to say. But remember, we're not just talking about verbal communication. We're talking about nonverbal. So you may be verbally sending one message, but nonverbally you're sending a totally different message. Channels are your means of sending and receiving messages. So that's visual, auditory, and tactile senses. And you may say, tactile, what does that have to do with anything? Well, if I give you a physical hug, or your loved one gives you a hug, they're sending you a message. They're sending you a message without even saying anything. They're sending you the message that they care about you. So that's one way that tactile. Feedback is the message a sender receives from the receiver. So it indicates whether the receiver understood the meaning of the message, and it occurs continuously. So I'm sending you a message, you're sending one back to me, and I'm understanding. That's your feedback. If we are in the classroom and I'm looking across the classroom and I see a bunch of faces and all your eyes look all glazed over, I know maybe we need a break, or maybe I need to clarify a topic, or maybe I need to ask you guys, what's going on. Interpersonal variables are factors within both the sender and the receiver that can influence communication. So culture would be one of them. In some cultures, the women don't communicate to the physician. So perhaps the patient might be the wife, but the husband's doing all the communicating. Another one might be men. In some cultures, men don't talk to women, or don't tell women about their health issues. So the patient may not really communicate much with you. So that's the variables. And then, of course, your environment, and that's a setting for the communication and making sure that that's a comfortable environment for everybody. All right, we're matching the basic elements of communication, guys. So, referent. What is the referent? I'm betting a bunch of you are going back and looking at the previous slide or your notes. So the referent is D. It's what motivates you to communicate. Okay. So again, referent is the motivation. Why do I need to communicate? What is the purpose? All right, number 2, sender and receiver. Absolutely A. The sender is the one who encodes, and the receiver is the one that decodes the message. All right, 3, message. Absolutely, it is G, the content. That's what the content, the information you're sending. Channels. Number 4, channels. What are the channels? Yep, it is E, the means of conveying and receiving messages. So that's how you do it. The means, the physical means that you do it. Number 5, feedback. What is feedback? Yep, C, the message that the receiver returns. Feedback. Interpersonal variables. What is 6? Sorry, guys. I made that one a little easy, didn't I? Yep, you're right. It's F. It's the factors that influence communication. And then 7, the environment. Which one is 7? Yep, B, the setting. So the setting for your interactions. Good. All right, forms of communication. So verbal communication. We're looking at things. Verbal is when not just spoken like oral, but it is also written word. That is verbal. Your vocabulary, you've got to be careful with that because a lot of times medical jargon can sound like it's a foreign language. So you want to try and limit your use of medical speak because it can be very difficult for patients. They don't understand it, their family doesn't understand it. And a lot of times you're going to have to be a translator between the doctor and the patient. Doctors forget that patients don't know what they don't know. Doctors just assume that everybody should know things, but they don't always do it. So, take for example, you have a patient that has to bring in a urine sample for whatever reason they're not doing it there at the office. So they may, if the doctor doesn't tell them you need to bring it in first thing in the morning, you need to keep it cold, they bring it in, 4:30 in the afternoon and it's been sitting out all day. Not helpful in the grand scheme of things, and that's because the doctor just assumed the patient would know. So we've got to be careful about that. Denotative meaning. Uh, Denotative meaning has to do with individuals who use a common language, and that common language shares a denotative meaning. So, for instance, if I say baseball, and it doesn't matter what country I'm in or what culture, they all understand what baseball is. So, but if I say football, I may be talking about American football, like NFL, but someone from, South America, Mexico, Europe, Australia, Canada, they may be thinking that I'm talking about soccer, what we call soccer here. So denotative meaning has to do with the meaning of the actual word. Does it mean the same thing to you and the patient? When I lived in Wisconsin and went to high school, one time my mom was asked where the bubbler was. She's like, what's a bubbler? I don't know where the bubbler is. She found out later they were talking about a drinking fountain. Now, some of you may call the drinking fountain a water fountain. And then some of you may say a water fountain is that stuff they put in front of houses or in the backyard and they have water. So that's where the denotative meaning, the meaning behind the word may be different. Is that making sense to you guys? Because that one's very tricky. So, other things you might do with vocabulary, good, is change your vocabulary based on age. So, if you're working with a child, you may dumb down your vocabulary a little bit. And I don't mean dumb as in stupid dumb. I mean dumb as in take it down to their level. Or you might also look at older adults. You want to make sure that you pace your speech, that you speak slowly and clearly and enunciate your words. Don't mumble. Because the mumbling isn't a very good thing and you can't understand a word it's saying. Right? That was very fast. You guys probably didn't understand a whole lot. Especially with older people or people with hearing issues, you really need to make sure that you speak slowly, you enunciate, you look at them, because people with hearing issues and of course deaf people learn to read lips. So it's really important. Your tone, the tone of voice you use, can dramatically affect your meaning behind your words. Oh, isn't that cute? Oh, isn't that cute? Two totally different tones in my voice, but you guys are going to perceive each message totally differently. So the first one, you might be like, oh, she's being sarcastic. She doesn't really mean it. And in the second one, I'm going, ooh, cute, fluffy puppies or something like that. So your tone makes a huge difference. So you need to be careful with your tone and be aware. Clarity and brevity. It needs to be simple, brief, and direct. Less words you use, the less chance for confusion. Now, I wish I could completely do that with your lectures, but it just doesn't work because there's so much to give you. So I do try to keep it as simple as possible. But keep it simple for your patients. You might have heard of the acronym KISS. Keep it simple, stupid, not meaning that you're stupid, but it's a good way to remember to keep things as simple as possible, as easy for the patient or whoever you're communicating to. And then timing. You probably don't want to communicate things to a patient coming out of anesthesia. Or maybe if a patient's having severe pain. If they're in labor and you're asking them a stupid question and they're trying to push a baby out, well, not a stupid question, that's bad, that's not appropriate, but you're trying to ask them a question that's not relevant to the situation at hand and they're focused on something else. The patient coming out of anesthesia, doctors are really bad about this. Surgeons, they'll come in and talk to the patient when the patient's like half out of it. They're awake enough to communicate, but they may not be awake enough to understand. So that's where it's important to make sure that your patient can not just communicate with you, but can also understand what's being communicated. Nonverbal, so personal appearance. So guys, this is why we put so much on the dress code, okay? Because your appearance makes a big difference. Once, especially when you're out in clinicals, that is your job interview, okay? When you're out doing clinicals throughout the rest of your schooling, that's your job interview. Once we get there, I know we're not in clinicals yet. However, your personal appearance to your professors also makes a difference. What if you need a letter of recommendation and you come to me and ask for that? If I don't think that you're professional, I may decline doing that. So make sure your appearance, you're well groomed, you're clean, you're neat, your uniform looks nice. Um, so for instance, when we go back to campus, you need to wear your scrubs, make sure they're in good order. You need to wear black, white, or gray shoes. Make sure those shoes are not mesh or any kind of fabric. Anyone with long hair needs to have their hair pulled up above the shoulders is specifically what it states. However, if you have longer hair and you have a ponytail, depending on the length, the reason for that is if you lean over the patient, we don't want your hair falling into whatever. Nails clipped down because that's a sanitation issue. You don't want to give or get an infection. And then I know there's a lot of things, gauges, earrings, tattoos. And a lot of people say, but a lot of employers don't care about my tattoos. And you're right, they probably don't. However, that is the dress code here, and that is what you're going to follow. So your personal appearance. Posture and gait make a big difference. If you walk with confidence, your head held high, your shoulders back, or do you hunch over and stare at the floor? Those are all nonverbal things I can tell. Facial expressions. I think this goes without saying. Y'all know facial expressions. If someone grimaces, you might say they're in pain or something like that. Do they make eye contact? If they're not making eye contact, why aren't they? Is it a cultural thing? Or maybe they're a victim of something and they feel dirty or whatever. Your gestures, I know exactly where Tim's going to go with this one. Not that gesture, but any other gesturing you might do with your hands. Sounds, so again, tone. Territoriality and personal space. Some cultures don't believe in personal space. If you've ever been to Disneyland, you know this. So be aware of that and what makes the patient comfortable or not comfortable. And then meta communication, that's a very broad term that refers to all of the factors that influence communication. So everything, meta communication, the whole thing of communication. And an awareness of influencing factors help you determine exactly what is communicated. Did I communicate the right thing or did I not communicate the right thing? And so I really liked this quote on here that I put from Ralph Waldo Emerson because it is so very true, guys. What you do speaks so loudly that I cannot hear what you say. First impressions are so important. So now the nurse-patient relationship. This is where you build the caring relationship, the therapeutic relationship. So you assume the role of a professional who cares, and hopefully you do care about your patients. If you don't, perhaps you should rethink your career choices. By using therapeutic communication, you help the patient attain health-related goals. You focus on the patient achieving optimal personal growth. Socializing is an important initial component of interpersonal communication. It helps relax you and it helps you get to know each other. So it's very important that you even just socialize with your patient, not just get into the nitty gritty, but start the conversation. So I may say, oh, Nathan, I'm going to pick on you today, Nathan. So nice to meet you. Now, why don't you tell me a little bit about yourself? Do you have any family? Do you have any, do you live alone? What do you do for a living? That kind of stuff. And that helps the patient start opening up and feel comfortable. And it shows them that you care about them. Tell me a little about yourself. You care about them as an individual, not just the patient in room 103. Encourage the patient to share their personal stories, or narrative stories, as they might be called. I will tell you guys, I love the older patients. They have such awesome stories, and they've lived through so much. So it's really nice when you can to sit and listen to their stories. Sometimes the older population just want to be heard. And then you can also tell stories to enhance patient education. I will tell you guys stories to enhance your education. So things that I found in the real world, and I'm telling you, this is what happened to me when I was a nurse. So it helps, well, not when I was a nurse, I'm still a nurse. Anyway, so it helps you to enhance what the patient learns, and it helps them to learn more. So you've got your phases of your healing relationship. So pre-interaction, that's where before you even go meet the patient, you reviewed all the information. You might talk to other caregivers or get reports. Might, based on the chart and the information, you might anticipate some concerns. Identify the location for communication. Make sure it's comfortable and private. If you're in the hospital, it's in the patient's room. If you're at home, if they're in a home health setting and you're working home health, make sure that they're comfortable. If there's family members around, they're comfortable talking in front of those family members. And then make sure you plan enough time. Sometimes all the planning in the world, you're still not going to have enough time, but that's when you can tell your patient, oh, I'd really like to go over some more, Mr. Jones. How about if I come back, or we'll do this at this time? So orientation. It's a meet and greet. That's where you get to meet each other. It sets the tone. Be warm and empathetic. It usually, this starts out as being kind of superficial and very tentative and uncertain. Expect the patient to test your competence and your commitment. And this is where it's important to not let them see you sweat. Try not to stumble if they ask you a question that you don't have immediately the answer to. If you say, I don't have the answer to that right away, but let me go look it up. And you come back and you say, I found it, it's this. Then you show confidence in that you will admit that you didn't know it off the top of your head, but you're competent enough to know where to find it. Sometimes it's not what you know, it's knowing where to find the answer. Closely watch your patient and expect that your patient will be watching you too. So body language is super important. You're going to start making inferences and judgments about the patient through their message and their behavior. Assess their health status and orientation. During orientation, you'll prioritize the problems and identify goals. You're going to make sure the roles are clear and kind of form a contract that specify what you will do. Okay, Mr. Jones, so I'm going to bring you your medications in about an hour now that I've completed my assessment. And then we'll give you a bath around 10 o'clock, and you have lunch at this time. So kind of it specifies. And then let the patient know when you expect the relationship to be terminated. If you're working a 12-hour shift, it's going to end at a certain time. So you're like, when you say, I'll be your nurse for today, they know. They generally have an idea. So now we get into the working phase where things get tough. It's where you and the patient work together to solve their problem. You want to encourage and help the patient express their feelings about their health. They may be scared. They may not feel indifferent. They may not care. Encourage and help the patient with self-exploration. So help them understand how they're really feeling. Provide information when needed so they can understand and change behavior. Encourage and help the patient to set their goals. Take your action to meet the goals set. So this is where you're doing your planning and your implementation. Use therapeutic communication skills to facilitate successful interactions. And then use appropriate self-disclosure, disclosure, and confrontation. So appropriate self-disclosure. Say you have a patient, we're going to go with this because they have pelvic inflammatory disease and they got a really bad infection in her uterus. So, and you're treating them, and perhaps she got it through unsafe sex. Probably not the kind of self-disclosure by telling them, oh yeah, I had chlamydia once, it was awful. No, don't self-disclose that kind of information, okay? That's a little bit TMI. So make sure your self-disclosure is relevant, but nothing too personal. You laugh, Natalie, but I actually had a student tell me about their STI, so in class, in front of the whole class. So, and then the termination phase, yeah. So termination phase, remind the patient, hey, the end of my shift is coming up. I just want to check in on you again and see if you need anything. Evaluate goal achievement with the patient. Did you achieve the goals you set for the day? Reminisce about the relationship with the patient. Separate from the patient by relinquishing his or her responsibility for his or her care. So that's when you're going to give report. And you may say, okay, Mr. Jones, it's the end of shift. I'm going to be giving report to Jane, and I'll see you tomorrow, or, hopefully you'll be gone before I come back to work in 2 days or whatever. And then achieve a smooth transmission for the patient to other caregivers. Okay. Motivational interviewing. So it's a technique that helps you encourage patients to share thoughts, feelings, beliefs, fears, concerns, with the goal of helping them change their behavior. Why do you think you feel that way? It's non-judgmental and it's kind of a guided approach. So it is a way of working with patients who may not actually be really ready to change behaviors, but those behavior changes are necessary for their health. It can be used to evoke what's called change talk, which links to improve patient outcomes. Obviously, if the patient starts talking about change, then maybe they might institute change. Try to understand what the patient's motivations and values. Use empathy and active listening. So make sure you're really listening to the patient and paraphrasing and actively listening to them. Make sure you identify the patient's concerns with their current health goals and behaviors and their current health status or the differences. So the patient might be, I don't want to be diabetic anymore. Well, Mr. Jones, you eat 2 meals a day out at McDonald's. So could we maybe cut that back to once a day? Or, Mr. Jones, understand that diabetes is very difficult. What kind of changes do you think you might be able to make? So that kind of gets them talking about the change talk, and it puts them back on them. Support the patient. They may be resistant and they may be ambivalent. A little progress is a little progress. At least it's moving forward. Focus on recognizing the patient and support strengths that help make positive changes. So make sure you show the patient what strengths they have in order to help make these changes. Professional relationships. You have the nurse family. So a lot of times you're going to have a relationship with more than just the patient. You may have the family members. You have the nurse and the healthcare team. So that affects patient safety and your own work environment. A breakdown in communication can cause serious injuries. So the nurse healthcare team relationship is the reason for what's called SBAR. And it is a common handoff report, situation, background. Oh my gosh, it just completely went out of my mind. But we'll talk about that more next week or Thursday. And then it helps in the nurse and the healthcare team using a common language. Now, lateral violence is a term used in with these relationships with the nurse and the healthcare team relationship. That is workplace bullying by coworkers. So that's one to be aware of and to be careful with. Then you have nurse community relationships. So participating in local organizations, volunteering, being politically active. It helps you establish relationships with your community. so you can be effective in instigating changes. All right, helping relationships serve as the foundation of a clinical nursing practice. Contracts for a therapeutic helping relationship are formed during A, orientation stage, B, working stage, C, termination stage, or D, pre-interaction. Okay, so the answer is A, orientation stage. So this is when you and the patient get to know one another and form contracts. And the patient that specifies who will do what is in the orientation stage. So this is, again, the answer to this is A. So the contracts are built when you're orientation. So you're setting the stage. You're setting, before you do the work, let's set the contract. So think about it in that sense. If you're having some work done, one thing you want to do from the contractor or whomever's doing the work, you want to set a contract. So that's your orientation stage. And then you're going to do the work after you have the contract set. Does that help? Is that a good, I think that's a good analogy. I don't know if you guys think so. But I think that really helps. Okay, so elements of professional communication. A lot of this is professionalism. Okay. So again, professional appearance, your demeanor and your behavior, that helps establish that you're trustworthy and that you're competent. You also want to use common courtesy. I mean, politeness. That's part of professional communication. Say hello and goodbye, knock on the door before entering, state your purpose, address people by name, and say please and thank you. Those are all really easy things, but things that we forget. So I may go knock on the door and I say, "Hi, Mrs. Jones. I'm Deirdre. I'm your nurse. Can I come in and do your assessment?" Mrs. Jones says yes. "Oh, thank you, Mrs. Jones." And then she said, "Oh, you know what? You can call me Jane." Then she gives me permission to call her by her first name. If you're going into a situation with a patient, sometimes the older people like to be called Mr., Mrs., Ms. So you may ask them, what would you prefer I call you? Is it okay if I call you Tom? Or do you prefer Thomas? You know, those kinds of things. Discourteousness is perceived as being as rude or insensitive, and that will set up a barrier. You know, that wall between here and Mexico will go up fast, will go up in less time than that wall if you're rude to a patient. Okay. Trust is relying on someone without a doubt. Trust is knowing that that person is going to be there regardless. Okay. So being trustworthy means that you help without even hesitating. You want to demonstrate consistency, reliability, honesty, competence, and respect. If you tell the patient you're going to be back in an hour, you better be back in an hour. So best way to say it is, okay, Mrs. Jones, I'll be back in about an hour. If I'm not back within an hour, it's because something came up with another patient, but I will be back to check on you within an hour or so. Trust involves a risk and a vulnerability, and the patient's already feeling very vulnerable because they're not able to do whatever to take care of themselves. You got to foster that that therapeutic communication. That trust helps that. It enhances expressing feelings, thoughts, and needs. Autonomy is when you're self-directed and independent in accomplishing goals and advocating for others. You take initiative to solve that problem. And then assertiveness is not the same as being aggressive. Assertiveness allows you to express feelings and ideas without judging or hurting others. This can include Things like intermittent eye contact, nonverbal communication, reflects interest, honesty, and active listening, spontaneous verbal responses, with a confident voice, and culturally sensitive use of touch and space. So, with you guys as students, part of my role as your instructor is to be an advocate for the students. So if the majority of the class comes to me and says, this policy is an issue, we have a problem with it, then it's my responsibility to be assertive with my higher ups and say, look, this is a problem. The students are complaining. The problem is I don't always get listened to, but at least I stood up and said, yeah, it's not right. We need to change that. You want to make sure you're self-assured, and that shows off with your assertiveness. But it's okay to learn to say no, set limits, and resist intentionally imposed guilt. So don't let people manipulate you into doing something because of guilt. Use I messages. I feel like, I felt, I am. And then some of you may have already learned this abbreviation, the ADET. A is acknowledge. Acknowledge the person. Introduce yourself. Hi, Mr. Jones. I'm Deirdre. Duration. How long is this going to take? Explain. And then thank them. Thank you for listening. So you're going to acknowledge, introduce yourself. That's where badges come in really handy. That's why we make you guys wear your badges all the time. So for those of you who don't have a badge with a photo on it, which is probably mostly online students, if you haven't done it already, there might be one or two of you, I think, that may have done it. When we get back to campus, you'll need to make sure your picture is taken so we can get you a photo ID badge, because when you go out in clinicals, you need to have that. Duration, you're going to give an idea how long something may take, and explain what you're going to do. And then at the end, thank them. Thank you. So, okay, we've been going for about an hour now. So I'm going to say, let's take a quick break, guys. Let's come back at 9:45. E is explain. So explain what you're going to do. So acknowledge, introduce, duration, explain, and thank. All right. So let's take a quick break, guys. About 15 minutes. So be back here at about 9:45 and we'll keep going, okay? Okie dokie. Moving on. So, nursing process assessment factors that can affect communication. You've got your physical and emotional or your psychophysiological factors, big word. So, physiologic status. Are they in pain? Is the patient hungry? Do they have nausea? Are they weak? Do they have dyspnea or shortness of breath? Those are going to affect whether or not the patient can communicate with you or wants to communicate with you. Their emotional status. Are they having anxiety? Are they angry? Do they feel hopeless? Are they euphoric? Their growth and developmental stages, also age, where they are in their developmental tasks, any unmet needs. Think of Maslow's hierarchy, guys. Safety and security, loving and belonging, their attitudes, values, and beliefs, what kind of meaning they put into their illness experience. Perceptions and their personality. Are they an optimist, a pessimist, an introvert, or an extrovert? Those things will all affect communication. I am pretty much an optimist. I have pessimism every once in a while, which is a good match for my husband, who is more of a realist. And I'm also more extroverted than some people are. And so it may be hard to get introverts to actually get out and talk to you. And then, do they have a negative or a positive self-concept or self-esteem? You have your developmental factors. Infant, their self-expression or ability to communicate is limited to cry. You've got to adapt your communication techniques to the needs of the infant and child and the parents. So in that case, you not just have to communicate with the child, but you also have to make sure you're communicating clearly with the parents. And then avoid patronizing older adults or sounding condescending to them. It's not that they don't have knowledge, it's they don't have medical knowledge, perhaps. Sociocultural factors. You have certain patterns that you may see in certain ethnic groups, but don't allow it to bias you. Don't allow certain stereotypes to be like, oh, well, my patient's going to be like that. They may not be. Use an interpreter if you're not proficient in the patient's language. Make sure eye contact might be an issue. Personal space and gestures may vary. In some cultures, the peace sign that we make with the two fingers is considered basically a middle finger. So you may just be aware of those things. And then also gender. Most of you may notice men use less verbal communication, but they are also more likely to initiate communication and address issues more directly. So they're not going to beat about in the bush. They're going to just flat out tell you. Men are actually more likely to talk about their issues. Women are more likely to disclose personal information and use active listening. And they'll answer in ways that encourage you to continue the conversation. So men start the conversation, women will share more and keep the conversation going. So some nursing diagnoses that you might use regarding communication: anxiety, social isolation, ineffective coping, compromised family coping, powerlessness, or impaired social interaction. All those might be issues. So impaired social interaction related to the inability to hear, as evidenced by patient uses sign language. There's your nursing diagnosis. Anxiety related to health condition, as evidenced by patient verbalizing they feel anxious, patient tachycardia, wringing their hands. So some therapeutic communication techniques. Specific responses encourage the expression of feelings and ideas and convey acceptance and respect. And you want your patients to feel like you accept them as they are and that you also respect them. So using active listening means that you're being attentive to what the patient is saying, but not just their verbal, but also their nonverbal. So they may be saying one thing in one tone, but non-verbally they're showing you something else. that's where you kind of need to delve deeper into what's going on. So there is actually a mnemonic for active listening. So helps if I type it into the. So the mnemonic is solar, not like solar power, which has an A, but solar. The S is sitting, or your posture that conveys the message. You're leaning forward and you're there to listen to them and you're interested in what that patient is saying. So your sitting posture. O is observe an open posture. So you want to be physically open. That means keeping your arms and your legs uncrossed. It suggests that you're open to what they're saying. And when you're closed, so when you cross your legs or cross your arms, it kind of gives off a more defensive attitude and it can provoke a similar defensive response in the patient. L is lean toward the patient. That conveys that you're involved and interested in the interaction. E is establish and maintain intermittent eye contact. So this conveys your involvement and willingness to listen to what the patient is saying. And an absence of eye contact or shifting of the eyes kind of gives the message that you're really not interested. And then R is relax. So you want to communicate that sense of relax and comfort because it'll make the patient feel relaxed and comfortable. So again, S is sitting, your sitting posture. O, observe an open posture. L is lean towards the patient. E, establish and maintain intermittent eye contact. And then R, relax, enjoy it. Observations, you may comment on how the other person looks, sounds, or acts. Sometimes this will help start a conversation with someone who's quiet or withdrawn, but don't state anything that will embarrass or anger the patient. So, for instance, observation, you may observe that the patient is overweight. You probably don't want to say, oh, are you pregnant? Because that would be really bad, especially if they aren't. Empathy, it's the ability to understand and accept another person's reality. You accurately perceive feelings and communicate the understanding to others. It reflects that you understand and feel the importance of the other's communication. And that's the biggest part with empathy, guys. You understand and you feel the importance of what they're saying. But this requires you to be sensitive and also imaginative, putting yourself in the patient's shoes. Hope is a sense of possibility. So you want to give some hope, encourage positive feedback. But again, be careful about how much hope you're giving. Humor. It is important to use humor. It is an underused form of communication. And it's actually a good coping strategy that helps reduce anxiety and promote positive feelings. There's a reason why they say laughter is the best medicine. It helps people feel joy and releases good endorphins. Feelings, sharing feelings. Now, remember, emotions are totally subjective. How I feel in a situation is not going to be the same as the way Davina feels in a certain situation. Stress and illness may worsen if feelings aren't shared. So if you don't allow your patient to communicate those, you want to make sure you make observations, acknowledge their feelings, encourage them to communicate, and go ahead and give the patient permission to express negative feelings. It's okay. And then model healthy emotional self-expression. Sharing emotions with patients can make you feel more human. And at times, the patients will direct their anger at you. It is not personal. They're just trying to vent, they're hurt, they're angry, and you're the first person there to lash out at. Touch is the most potent, but also most personal form of communication. It establishes the feeling that you're connected and that you care. but you need to be sensitive to reactions and culture. So I'm very much a hugger person. It frustrates me sometimes when I can't hug people. But when I was seeing patients as a nurse practitioner, I would ask, can I give you a hug? You look like you need a hug. Is that okay? Um, and usually studies have shown that a 20 to 30-second hug can actually really help someone. Silence. Silence is really hard. I'm having a hard time with it because right now you guys are silent because you're all muted, and I feel like I need to keep talking. It takes time and a lot of experience to get comfortable with silence. And when you're silent, it will promote someone, it may promote someone to actually speak. So it's hard to do, but stay silent and the patient will start speaking to you. It gives them the time to think and gain some insight. And it can be very therapeutic during times of profound sadness or grief. Sometimes just being silent and, holding their hand. And then provide information. It gives the information that you need or want to know. It helps the patient make decisions. They don't have as much anxiety and they feel safe and secure. So by providing information, talk to them about a procedure that's going to happen or what you're going to do. I'm going to start your IV. These are the steps I'm going to take before you even do anything. Clarifying is when you make sure you understood the message correctly. Basically, you restate anything that's unclear or ambiguous to you. I'm not sure I understand. What I hear is focusing helps center the conversation on a key element or concept. If it interrupts the patient while they're discussing an important issue, don't do that. Don't interrupt the patient. Make note of, oh, I want to go back and focus on this, but don't interrupt the patient. Paraphrasing is how you restate a message maybe more briefly and using your own words. It's a feedback. It lets the patient know that you really are actively listening and trying to understand. Paraphrasing requires a lot of practice. Validation. It's used to recognize and acknowledge a patient's thoughts or feelings and needs. Patient needs to know they are heard and taken seriously. I understand you're having a lot of frustration right now. And it's okay. This is an unusual situation for you. Asking relevant questions. Ask one question at a time and then fully explore that before you move on to another topic. Okay. So don't throw a bunch of questions at the patient. Do one at a time and then explore more. Summarizing is kind of like paraphrasing. It's a review of key aspects and helps you clarify. Self-disclosure, again, we talked about sharing personal experiences that are relevant. It shows the patient that you understand their experience, that, hey, you've been there. How many times have, a patient may have said something to you and you're like, oh, I understand that. No, you don't. You haven't been there before, or even your kids. That is something that's going to happen. And that's where you would come to, well, actually, I was in this situation, or you're right, I haven't been in that situation. So I think back to the scene in Harry Potter and the Order of the Phoenix at the very end, when Harry's in Dumbledore's office after the fight at the Ministry of Magic. And Dumbledore says to Harry, I understand how you feel. And Harry says, no, you don't. Because Harry lost Sirius, the only person that he felt really, really cared for him. And once you get through the whole series, you understand that, yes, Dumbledore really does understand how Harry felt. But he didn't take it any further to say, well, I lost my sister. So. And then confrontation. You help the person become more aware of inconsistencies in his or her feelings, attitudes, beliefs, and behaviors, but use this only after you've established the trust, and do it very gently and with sensitivity. You don't want to be confrontational or aggressive about it, but you want to maybe make them see, well, you said this, but you're doing that. So, but it helps them see, oh, well, yeah, that doesn't make any sense. A lot of times people don't like it and they'll try and cover themselves up. Well, that's, I don't care, you know. So use that one sparingly. Okay, so we talked all about therapeutic communication. Now we're getting into those things that are not really therapeutic and are going to damage your relationship. Asking personal questions, only if they're not relevant. If they're not relevant, or if you're just being nosy, and they may be really invasive and unnecessary, don't do that. It's not therapeutic. Giving personal opinions, never, ever, ever. It takes the decision away from others, and it inhibits spontaneity, and it stalls problem solving and creates doubt. So, for instance, well, in my opinion, and then the patient goes, well, maybe they're right. Well, maybe I should do that. Well, maybe I should do that. Now, if the patient says, well, what would you do? That's a different. Um, they're seeking it out. Don't change the subject. It's rude. And it shows that you lack empathy and you don't care. Automatic responses, stereotype remarks, generalized beliefs about people, and automatic responses reflect just poor nursing judgment. False reassurance will do more harm than good. And it helps you, basically all it does is it helps you to avoid that patient's distress. Sympathy, totally different from empathy, where you understand where they're coming from. Sympathy is concern, sorrow, or pity. People don't like it when you take pity on them. And you can also lose objectivity. Asking for explanations, depending on how you do it, can be interpreted as accusatory or they're being tested. And then approval or disapproval. Don't impose your own beliefs, attitudes, values, and morals. Defensive responses implies that the other person has no right to an opinion and that the sender's concerns are completely ignored. Passive or aggressive responses, they're done to avoid conflict or sidestep issues. And they can reflect feelings of sadness, depression, anxiety, powerlessness, and hopelessness. And then, of course, arguing. You're challenging a perception. Excuse me. Can be perceived as that you're denying that their perception is real and valid. Perception is everything. Perception is the truth, whether it is actually the truth or not. Adapting communication techniques. So we have a lot of issues. I mean, you guys can probably think of patients hard of hearing. Then you have patients who are blind. You have patients who are deaf. You have patients who have cognitive impairments. So this kind of communication, you have to put a lot of thought and sensitivity into it. You might use communication aids like a writing board or a special call system. Last term in clinicals, term before last in clinicals, had a patient that's quadriplegic, so she can't use her arms and legs. What are you gonna do with a call button? So they had a special call button to put up on her shoulder, and she could lean her head to one side to push the button. Cognitive impairment, you might use pictures, drawings, or do a demonstration. For children, you might, for pain scale, FACES scale, to kind of determine where their pain level is at, because the picture works better. Whatever method you guys determine to use for your patient, make sure that the patient is actually physically able to use that method. If they can't physically use the method, you're still not going to get any communication. If they're not English speaking, make sure you use an interpreter. And you can kind of determine if they really are pretty proficient in English if they're not. The other thing to keep in mind, unresponsiveness. Patients who are unresponsive can still hear you. Guarantee you 100%. They say hearing's the last thing to go, and it definitely appears that it is. Anecdotally, people who have been on the other side, or people who are in a coma may say, they couldn't communicate, but they could hear everything that was going on. So please be aware of your communication in an unresponsive patient's room. Also, anyone who seems visually or cognitively impaired, don't underestimate. All right. Well, while admitting a patient during the initial interview, a family member tells you, my mom really means that she does not understand her medical diagnosis. The communication form used by this family member is A, focusing, B, clarifying, C, summarizing, or D, paraphrasing. Okay, so the answer is B. It is clarifying. So when someone like a family member of a patient tries to explain what they believe the patient means, they're trying to clarify to make sure that you, the nurse, understands. Oh, cool. Time for Kahoot. All right, everybody, make sure you get into your Kahoot. All right, guys, there you go. The code is 215-7208. Should be one more. Not sure who's missing. Now we're losing people again. All right, but we'll get this started because we've got a lot to cover. Okay, for communication to be effective, use words that have the same meaning for the sender and receiver. Use terms that are unfamiliar to residents and families. Add unrelated information, or answers should not be specific. Yes, same meaning. Nonverbal communication includes body language, eye contact, and gestures, spoken words, signs, and symbols, yelling, or writing. Nonverbal is body language, eye contact, and gestures. Writing is actually considered a form of verbal. Oh, I'm sorry, Lyra. Verbal communication. Speaking of, verbal communication is sending a message without using words, posture, gestures, facial expression, body language, sending a message in words, or communicating with oneself. Yep, sending a message in words. Ooh, what are the elements of the communication process? Messenger, share, respond, and response. Messenger, sender, receiver, channel, and feedback. Messenger, sender, receiver, and channel. Or bread, peanut butter, and jelly. Yep, it's the messenger, the sender, the receiver, channel, and feedback. Well, it should be message, sender, receiver, but yeah. What is an effective communication rule? Ignore a person's problems, hurry them up, talk quickly, or be patient. Awesome. So, what is the purpose of therapeutic communication? To encourage expression of feelings, to encourage yes or no answers, to speed up the discharge process, or to gather information about the patient's family. Yep, to encourage expression of feelings. Gather information about the patient's family that could be part of your communication, but therapeutic communication helps the patient feel better. So they may be expressing their feelings. Using touch as a means of therapeutic communication conveys disappointment, is inappropriate, and should not be used. Approval or disapproval, or feelings of connection and encouragement. So again, touch, you need to make sure that your patient's okay with it. But it is not inappropriate at all times, and there are times when it should be used. But it does help encourage feelings of connection. What are skills you might use to facilitate therapeutic communication? Asking specific questions requiring a yes or no, restating and reflecting, discuss issues using the appropriate medical terminology, or ask family and friends to lead to ensure privacy. This might be a multiple answer one, guys. Okay, it's not. So for those of you who did ask family and friends to leave to ensure privacy, it could help with therapeutic communication if they're in an abusive relationship. But honestly, restating and reflecting is a skill that you're definitely going to use. You don't want to use yes or no questions. You want open-ended questions. And you don't want to use medical jargon because the patient may not understand. True or false? Active listening is a form of therapeutic communication. Yep. Which comments by a nurse demonstrate their use of therapeutic communication techniques? Why do you think these events have happened to you? There are people with problems much worse than yours. I'm glad you were able to tell me how you felt about your loss. You look very nice today. I'm proud you took more time with your appearance. That definitely is a good therapeutic communication technique. I'm glad you were able to tell me. It helps the patient. Number one, you're kind of restating what you discussed, and it encourages the patient. I'm glad you told me that. I feel good, so it'll make them feel better. Now, why do you think these events have happened to you? It's kind of argumentative or confrontational. Well, why do you think this is happening? And then you look very nice today. Starts out really good. I'm proud you took more time with your parents. Well, if they usually take time with their parents, but this particular day they just look a lot better than others, and that's not going to be so good. What are the phases of a helping relationship? Pre-interaction, orientation, working, and termination, sharing empathy, clarifying, or summarizing. Pre-interaction, working, providing information, summarizing. Orientation, termination, sharing empathy, asking relevant questions. It's the pre-interaction, orientation, working, and termination. Remember, pre-interaction is where you review the chart, you get report. Orientation is where you introduce yourself and kind of let the patient know the focus. Working, and that's orientation is where you develop the contract. And then working is where you work towards helping the problem. So you're implementing the plan. And then termination, things are coming to a close. So you summarize what's happened and you let the patient know when the relationship is going to end. What is the goal of the nurse in a helping relationship with a patient? To provide hands-on physical care, to assist the patient to identify and achieve goals, to ensure safety while caring for patients, or to facilitate the patient's interactions with others. So yes, so a helping relationship assists the patient to identify and achieve goals. You're helping them identify and achieve their goals. Ensuring safety, it's not the goal of the helping relationship. And you should always do that. Last one. What action by the nurse will facilitate the helping relationship during the orientation phase? Providing assistance to meet activities of daily living, introducing him or herself to the patient by name, designing a specific teaching plan of care, or preparing for termination of the relationship. Yes. So orientation phase, you're going to go introduce yourself to the patient. Providing assistance will happen more in the working phase. And then the teaching plan of care, you're more doing that towards the working phase where you're actually developing that care plan. Good job, guys. I know some of you had delays, and I wish I could do something about that, but I think it just is what it is. I can't really change it. It's working on my end, so way to go. That one's a hard one. Communication is really kind of a hard chapter. I'm leaving. Back to there. All right, so what time is it? Before we get into this again, because this is going to be really long, guys, let's take another quick break, just like 10 minutes. Be back here at 10:30. And just be prepared because there's a lot of information here, guys, okay? So yeah, go get everything settled and then be back here at 10:30. How are you guys doing? Everybody doing okay? Normally, I'd have you guys do communication exercises with each other, but of course, not being in classroom together. If Christina, on the when you move your cursor around, you get that little bar that shows like the microphone and the little phone. If you there's a little chat uh icon, if you click on that, you can see that. Oh, that sucks, Jessica. Hmm. I will see if Miss Marta might know a workaround for that. All right, on to health assessment and physical exam. So this is where you identify health patterns and evaluate the patient's response to treatment and therapies. Uh, a complete health assessment involves your nursing history as well as the behavioral and physical exam. So the patient's condition and response affect the exact. Yeah, it doesn't look like you have the chat feature. Hmm. So the patient's condition and response affect how the extent of your exam. So if you are doing a focused exam, you may actually focus on certain areas. But if you're doing a comprehensive, you may do a head-to-toe exam. And the accuracy of your assessment influences the choice of therapies that are made and the evaluation of a patient's response to those therapies. So, purposes, you're going to, through your initial evaluation, to triage them. You may be doing routine screening, insurance, military service. I have, as a nurse practitioner, I had a couple that I had to do physicals for military, admission. So you're using your physical exam to gather your data. Now, after you consider your patient's current condition, you're going to select the focused physical exam on a specific system or area. So you're going to look at, okay, what is it I need to really look into and address? And you can integrate getting this data, physical data, during patient care and use it to validate your findings. So for instance, if you're helping your tech give your patient a bath, that's a good time to look at their skin. If you're doing wound care, that's the time where you're going to assess their wound. So you're doing more than one thing at a time. When you're sitting and talking with your patient, you're taking in their general appearance, their posture, nonverbal cues like pain. So those are all things that doing, even though you may be doing something else. So when you meet a patient for the first time, it's important to establish a baseline assessment. That enables a nurse to refer back to A, physiologic outcomes of care, B, the normal range of physical findings, C, a pattern of findings identified when the patient is first assessed, or D, clinical judgments made about a patient's changing health status. So actually, the answer to this is C. So the baseline assessment findings are a pattern of findings identified from a patient when the patient is first assessed. The baseline assessment findings reflect a patient's functional abilities and serve as the basis for comparison with subsequent assessment. So it is that pattern. You're looking for the patterns when you first assessment. Cultural sensitivities. So we need to be open to a patient's culture. Make sure you're avoiding stereotyping and being culturally aware. Don't be afraid to ask questions if you don't understand. I know I've discussed this before. If you're not sure about a patient's cultural beliefs, ask them. And then learn to recognize some common characteristics that you might see. Now, keep in mind, in some areas, you're going to have you may have so you have someone who's Jewish, but are they Orthodox or Roman? So there's different. Then you have Catholic. Are they Roman Catholic? Maybe they're Episcopalian. Are they so all those different things that you need to look at. So you're going to consider their beliefs about health, their beliefs in the alternative therapies, their nutritional habits. They may or may not eat certain foods, relationship with their family, their personal comfort zone. So in order to prepare for an exam, this is a routine part of your physical assessment. You want to make sure that you're organized. That way you don't have that many interruptions and the exam goes more smoothly. Eventually you will get more of a groove and it'll be second nature to you guys. So, of course, with infection control, you're going to use standard precautions and any additional PPE is needed. Make sure you're using hand hygiene and be careful with latex allergy. Make sure you know whether or not your gloves are latex free or any other equipment you might use. The environment, make sure you're providing privacy, make sure it's equipped correctly, there's good lighting so you can see things, and make sure you get rid of any extra noise, so shut a door, and make sure it's warm for comfort. When I was practicing at my last clinic, the clinic was it's part of a certain group of clinics, but it was in Pima Community College East, and we had zero control over the environment. So our exam rooms were freezing, and we kept calling them and telling them, and the guys kept going, oh, and finally I actually looked at one of them and I said, okay, you guys get naked and put on a gown and sit in this room for 5 minutes and let me know how you feel. I mean, it really was frustrating, but I had zero control over that. So I did whatever I could. So sometimes that meant leaving the patient in their clothes and this kind of working around it and doing the best exam I could. Equipment, again, make sure that you have all your equipment. You have kind of a little list there. There's one for like pap smears, cervical brush, cotton applicators, disposable drapes, eye chart, flashlight, any forms that you need, non-latex gloves, gown, ophthalmoscope, otoscope, some of those things you guys will not be using as a nurse. And then physical preparation. So make sure the patient is comfortable and their comfort needs are met. Make sure they've gone to the bathroom. Make sure you drape them as necessary. Make sure they've had pain medications. And you want to make sure you position them properly so that body parts are accessible, but maintain respect and consideration. And then try to organize your exam to decrease repositioning. So, for instance, if a patient is laying on their back or supine, you're going to do your assessment of the front side of their body first before you do the back. Okay, so you may not go system by system. You may do your systems head to toe in the front, have them roll to their side, and do their head to toe assessment from the back. That makes it much easier. The patient doesn't have to roll around and move as much, and then you're not doing as much either. Psychological preparation, so just letting them know the purpose and what you're going to do, the steps of the exam. Let them know what they should expect and what you might need them to do during the exam. Make sure you remain relaxed and very professional. Watch the patient's emotional responses, and if the patient doesn't want it, don't force it. If they say no, that's okay. And then assessment of different age groups. So your approach is going to vary with every age. With infants and children, you want to make sure you talk to the parents and guardians. You're going to have to gain the child's trust. Parents will sometimes think you're testing them, so be supportive and don't be judgmental. Call the child by their first name. And then with adolescents, you want to treat them as an individual, as a kind of like an adult. So a lot of times when they get to be about 13, 14, I may ask if, they want the parent to step out of the room so I can discuss sensitive topics with them that maybe they don't want their parents to know. Very cognizant of making sure that I'm asking, in an adolescent, I'm asking them. If the parents interject or if the adolescent looks to their parent, that's one thing. Also, don't stereotype about cognition related to aging. Make sure you realize that some older adults may have sensory or physical limitations. Make sure you have adequate space so that they can use any mobility devices. Be patient. Allow for pauses and observe details. And then certain types of health information are stressful to give. They seem kind of threatening to independence. Be aware of the nearest restroom. Make sure you're alert for signs that the patient's becoming fatigued, like sighing, grimacing, irritability, leaning on objects for support, and drooping head or shoulders. So organizing your exam. You're going to make sure you're doing a relevant exam and getting the correct assessments. If you're doing focused symptoms or needs, only expose the parts of the body that the patient you really need to see. So if you're doing a head to toe, you're going to do each body system. You want to make sure it's systematic and organized. So head to toe, you're going to look at symmetry of both sides. You're going to look at the body systems most at risk for being abnormal. For instance, if you have a patient with chronic obstructive pulmonary disease, you're going to focus probably on their lungs, their heart, and the vascular system. You may not be as worried about, say, their abdomen or neurologic system. You're going to offer periods of rest. Make sure you do anything that might be painful at the end of your assessment. Be very specific when you record your assessment. When you're recording, use common terms and abbreviations. And you can also go in, you have your notes where you're taking your notes during your report. So you might make notes on there so that you can do a larger note at the end of the exam. So the techniques of physical assessment, there are 4 techniques you're going to use: inspection, palpation, percussion, and auscultation. So inspection is where you're looking, listening, smelling. This occurs when you interact with the patient. So you want to make sure you recognize the nature and the source of body odors. So that's why you're going to need adequate lighting, both direct light and tangential, so an overhead light. You want to make sure you use direct light to inspect body cavities. If you have them open their mouth and say, but you don't shine your pen light in their mouth, you're not going to see a lot. Look for size, shape, color, symmetry, and position, and any abnormalities. Position and expose body parts as needed, so you maintain as much privacy as possible. So if you need to examine their legs, expose one leg at a time. And then validate any findings with the patient. If you find something, you're like, this is unusual. Have you had this before? And the patient might be able to tell you. Palpation is your touching. You can use different parts of your hand to detect different characteristics. So the palmar surface or the palm is more sensitive than your fingertips. So that portion, the palm, should be used to determine your position, texture, size, consistency, any masses, fluid, and crepitus. Crepitus is that crunching you get in joints usually. You are going to assess body temperature with the dorsal surface of your hand, so that's the back of your hand. Personal experience, display respect with them. Make sure you're prepared as much as possible by warming your hands. It's not always possible. But I try to rub them together to get them kind of warmed up. And I always apologize to my patients if my hands are cold. Make sure you keep your fingernails trimmed. Use a gentle approach initially when you're palpating. Proceed slowly, gently, and very deliberately. And make sure you use both light palpation, and then deeper. So percussion is an interesting one. You may not use a whole lot. It's where you tap the skin with your fingertips, to vibrate underlying tissues and organs. Character of the resulting sound reflects the density of the underlying tissue. So denser tissues will have a quieter sound. An abnormal sound might suggest a mass or a substance. And then auscultation, that's listening, that's the stethoscope. You're listening to internal sounds that are created by blood, air, gastric contents as they move against structures. You need to be able to hear well and have a good stethoscope and know how to use it. If you have hearing issues, you may want to get an amplifying stethoscope. They're expensive, but it'll be worth its weight in gold. Keep practicing. So for those of you who have stethoscopes, if you practice at work, if the nurse notices something unusual, hey, can I listen to that? Or practice on your family members. Frequency is the number of sound wave cycles generated per second by a vibrating object. So again, frequency is the number of sound wave cycles generated per second by a vibrating object. So higher frequency, higher number of sound wave cycles, the higher the pitch. Loudness is the amplitude of the sound wave. So I'm trying to find another word than loud, but how oh my gosh, volume. Thank you, Natalie. So the higher the volume, the higher the amplitude. Quality is sounds of familiar frequency and loudness from different sources. So you may have blowing, gurgling, and you may have those in different areas. And then duration is the length of time that the sound vibrates. So first you start with your general survey, and this is when you observe the patient immediately when they walk in the room. Look at their body type. Are they thin? Are they obese? Excuse me. Look at their gait. Is it coordinated? Is it smooth? Are their arms swinging freely at their sides? Those are normal. Body movements. Are they purposeful? Do they have tremors? Their affect, how the patient appears to other. Is their speech understandable and moderately paced? Are there any signs of abuse that you can observe? Any obvious injury, behavior? If you suspect any abuse, try to interview the patient privacy, so without the potential abuser. Also, you are a mandated reporter. If you suspect abuse, you have to report it. So there is CPS, which is Child Protective Services, and APS, which is Adult Protective Services. If you suspect that an adult is being abused, you can go to the APS website and file a report online. Okay. If it is a child, there is a number. You can go to the website, but you cannot file a report. They will give you a number and you must call and file a report. So adults, you can do online. Children, if you suspect abuse, you have to call a phone number. Substance abuse, you might use a screening tool like CAGE. So C is cut down on drinking or drug use, so the need to cut down. A is annoyed, so people annoyed you by criticizing your drinking or drug use. G is guilty. Have you ever felt guilty or bad about your drinking or drug use? And then E is eye opener. Have you ever used or had a drink first thing in the morning as an eye opener to steady your nerves or feel normal? So again, CAGE is C is cut down, felt the need to cut down. A is annoyed at people telling you need to cut back. Or G, guilty because you about your drinking or drug use. And E, the eye opener, having to have a drink or use drugs first thing to feel normal. After you're done with your initial survey, you're going to take vital signs. This is most accurate if it's completed before a lot of position changes and movement. If you get an abnormal reading, recheck it. Assess weight trends, screen for any abnormal changes, like a weight gain of 5 pounds in a day, which could indicate fluid retention, or weight loss of greater than 5% of body weight in a month, or 10% in 6 months. So if a patient weighs 120 pounds, 5% body loss is going to be 6 pounds. Because you're going to move the decimal 1 to the left to make it 10%, and you're going to cut that in half. So that makes it 12, and then half of that would be 6. So that would be 5%. If you're doing daily weights, make sure you're doing them at the same time of day with the same amount of clothing on the same scale. Make sure you're measuring height without shoes if they're able to stand, and make sure they're standing on a surface that is clean. Gross. Nothing worse than having a patient take off their shoes and stand on the floor and the floor is dirty and gross. If they are not weight bearing, you can lay the patient down without shoes and then measure them from head to the bottom of the foot. That one can be a little tricky because you're going to have some sort of tape measure or something. Okay, skin, hair, and nails. So you're going to begin with the health history. And the health history for skin can be found on page 545 if you want to review that. It's table 31-7. Inspect all the visible skin surfaces. Skin actually reveals oxygenation status, circulation, nutrition, any local tissue damage, and hydration. You need adequate lighting. Daylight is the best. Fluorescent is next best. You're going to look at their color. There is going to be some variation from person to person and body part to body part. The best place to assess skin color is on the areas that are not exposed to sun, so palms of the hands. Moisture refers to how wet or oily the skin feels. Temperature indicates the amount of blood circulating. Texture tells you the character of the surface of the skin and how deeper layers feel. You might have, it might be smooth or rough, thick or thin, tight or supple, indurated, which is hardened or soft. You're going to look at turgor, which indicates elasticity. That's very important for people who with checking hydration status, but then turgor also will decrease with age. You're going to look at vascularity. Are they pink? Are they red? Are they pale? Also looking for petechiae with vascularity. They're non-blanching, pinpoint size red or purple spots caused by small hemorrhages in skin layers. So petechiae, they're non-blanching, pinpoint, and they're red or purple spots. Edema is swelling or excess fluid in tissues. You're going to inspect those edematous areas for, number one, note the location. Look at the color and the shape. You might also look at the skin and moisture. A lot of people with edema, like in their lower extremities, have very dry skin. Edema can separate the surface of the skin from pigmented and vascular layers, and it can also appear stretchy and shiny. Lesions, you're going to look at any unusual findings on the skin surface. So right there, you guys have the different findings, lesions you might have. The macule, which is flat and not palpable. It's a change in color and less than 1 centimeter. The papule, which is palpable, circumscribed, so you have clear edges. It's solid and it's smaller than 1 centimeter. A nodule, which is an elevated solid mass. It's deeper and firmer than a papule and can be 1 to 2 centimeters. Tumor is a solid mass that extends deep through sub-Q tissue, and it's going to be larger than 1 to 2 centimeters. A wheal is an irregularly shaped, elevated area or superficial localized edema. It can vary in size. So things you might see with a wheal are hives or a mosquito bite. Vesicle is a circumscribed area of elevation that's fluid-filled. Generally, it's serous fluid, which is clearish, and it's going to be smaller than 1 centimeter. Pustules are also circumscribed elevations, but they're filled with pus, and they can vary in size. Ulcers can be deep loss of skin surface, extends to dermis. It bleeds and scars and will vary in size. And then atrophy is a thinning of the skin with loss of normal skin furrow. The skin will appear shiny and translucent and can vary in size. Common lesions you'll find are freckles, some age-related changes such as skin tags, senile keratosis, which is a thickening of skin, cherry angiomas, which are ruby red papules, atrophic warts. When you're looking at skin for abnormalities or lesions, you want to use A, B, C, D. A stands for asymmetry. Is it an uneven shape? Okay, it's not a perfect circle. It's kind of odd. It's not symmetrical. B is border. So you want to look for any irregularity in the border edges that might be blurred, notched, or look ragged. Color. Is the color uniform or not? Is it different or is it all one color? And the diameter is D. How big is it? If it's greater than 6 millimeters, that's an issue. It's indicative of skin cancer. And 6 millimeters is about the size of a pencil eraser. Then we get into hair. There are actually two different types of hair. There's that soft, fine vellus hair, which covers your body. And then the coarse, long, thick terminal hair, which is visible on the scalp, axillary, and pubic areas, and also facial beard on men. Although some women have some of that coarse hair, terminal hair in a beard kind of area. You're going to look at the hair for color, distribution. Is it thinning? Is it thick? Is there a balding pattern? Quantity, thickness, texture, and lubrication of the body hair. Is it oily? Scalp hair is coarse or fine. And then curly or straight, and can be coarse, fine, curly, straight. Should also be shiny, smooth, and pliant. You're going to want to separate sections of hair to look at their scalp. When you do that, make sure you're wearing gloves. If a patient is having hair loss, it can indicate a thyroid issue, alopecia, which is just a hair loss disorder, and some other disorders, but those are the most common, are thyroid and alopecia. Make sure you note any lesions on their scalp. Inspect their follicles of the hair. Nails. Nails can reflect general health, their state of nutrition, possibly an occupation, and then habits of self-care. The vascularity of the nail beds creates that underlying pink color. At the base of the nails, there's that semi-lunar whitish area. It's called the lanula, and that's where the nail plate grows. Now, for instance, on my right index finger, my lanula is abnormal. I slammed that finger in a car door, and it's been like that ever since. So you're going to see that, and you're like, oh, what happened there? And you're like, oh, that's an injury from years ago. You're going to inspect, so you're going to look at their nails, and you're also going to palpate. You're going to palpate for, are they smooth? Are they rough? Are there any ridges? So inspection, you're looking for the color of the nails, the length. Are they symmetrical? Are they clean? And configurations, are they square? Are they oval? Are they clubbed? You're going to look at thickness and the shape of the nails, texture, the angle between the nail and nail bed, and the conditions of the fold around the nails and the cuticles. You want to find a firm nail base when you palpate. So when you push on it, you want it to be firm. And of course, check for any redness or swelling. So again, some colors that you might see. So bluishness in the nail beds is from deoxygenation. Pallor or a decrease in color, decreased oxyhemoglobin. Loss of pigment in skin can indicate vitiligo. A yellow orangish color is usually jaundice due to bilirubin. Redness or erythema, increased oxyhemoglobin. And then tan or brown is an increased amount of melanin. But again, that can be normal depending on the patient's ethnicity. So the other thing with this to keep in mind, we talked about oxyhemoglobin. Carbon dioxide loves hemoglobin, and that will create more of a cherry red color in the nail beds. So if you see a bright red cherry color, think possibly carbon monoxide. All right, patient complains of thirst and a headache. Patient appears emaciated. Upon initial exam, you find the skin does not return to normal shape. This finding is consistent with A, pallor, B, edema, C, erythema, or D, poor skin turgor. So the answer is actually D, poor skin turgor. So when you're checking for turgor, you're going to kind of pull up a little on the skin and make a little tent. And if it goes back into position, they have good skin turgor. But if it doesn't return to normal and it kind of stays tented, that is definitely an abnormal finding. Edema is more like a swollen area. Now the skin turgor may be affected, but definitely things you're looking at, they're emaciated, they may be dehydrated, so they're not, their skin turgor is not going to return to normal there. Okay, so head and neck. The head and neck exam includes their head, obviously, eyes, ears, nose, mouth, pharynx, so their throat, their neck, so their lymph nodes, carotid arteries, thyroid gland, and trachea. Now, when taking a carotid pulse, do we check both sides at the same time? Good. I'm glad you guys got that. So, um, and this is a good instance of, you can see that in the bottom left picture, she's inspecting the scalp. So you don't necessarily have to do all the skin assessment at one time. So you're going to do a head and neck assessment. So that's a good time to do part of the skin assessment where you're looking at their hair and their scalp and the skin on their head and neck. So keep that in mind to try and keep it more focused. So rather than, oh, I'm looked at all your skin. Okay, now I'm going to go back to your head. You can do all those things as you're going down the body. Inspection and palpation is usually done at the same time. So as you can see, she's inspecting and touching. Your nursing history will screen for any intracranial injuries and local or cognitive defects. Is the head midline or does it tilt to one side or the other? Does the head jerk or bob, which is more of a tremor? Absolutely, Veronica. And then inspect facial features for symmetry. Now, keep in mind, most people are not completely symmetrical. So a little asymmetry is okay, but a lot, not a good thing. So this is a quick little, I just thought, So you want to be like this monkey, okay? Except you're going to wear gloves and you're not going to eat what you pick out of their hair. And there's no sound, so don't worry about it. I mean, he's doing a really good hair exam, going through all of it. Whoops. Now I did it. I don't know why I have that up there twice. Okay. No. Eyes. So you're going to assess their visual acuity, their visual fields, extraocular movements, and this external and internal eye structures. You're not going to be inspecting internal eye structures. That is above your pay grade. So as a nurse, I did not do that. As a nurse practitioner, however, I did use the ophthalmoscope to inspect the retinas and blood vessels in their eyes. So visual acuity, generally you're going to be using a Snellen chart. And that's the one they put on the wall with the big E and then the letters progressively getting smaller. It helps to determine the ability to see small details. It tests their central vision. With the Snellen chart, you literally have to measure 20 feet from the chart because that's 20/20. So when you hear someone has 20/20 vision, they can see well at 20 feet away. You're going to assess near vision by asking them to read a handheld card that has a vision screening chart. Extraocular movements. We're talking about 6 muscles. They control both the eyes. Hopefully, they're going to move parallel to each other. If they don't, that's an abnormal finding. You're going to stand about 2 feet, and then you're going to do the cardinal fields. Now, this one has a lot more than the cardinal fields in this, but you're going to do basically whiskers of a cat, okay? So you're going to do side to side and then diagonal in each direction. So let me see if I can pop up the whiteboard here. No, it's not popping up. Where's my whiteboard? Yeah, just missed that. I don't know why I have 2 teams up. That's weird. Weird. So I wanted to find the whiteboard. It's not working. So sorry, guys. So I am going to not pictures. Where are my lines? Shapes. So you're going to do this. Well, whoops, not that one. Sorry. Back up. Not that one. Shapes. You do this. So across. Okay. Then you're going to go diagonally. Okay. And then you're going to go this way. So that is cat whiskers. So if you think these are the whiskers of the cat above their little nose and the little cat mouth and the eyes. So that is what we're talking about when we're talking about the cardinal fields and the extraocular movement. Okay, nystagmus, when you in the extraocular movement, is an involuntary rhythmical oscillation of the eyes. It results from a local injury to eye muscles and supporting structures, or a disorder of the cranial nerve. Okay, so you may see nystagmus. Visual fields, you're looking, asking a patient when they can see your fingers. So you're going from the side, so kind of behind into behind in each side, and you're moving around, and you could do one at a time and have the patient tell you when they start seeing. That looks at their peripheral vision. And then you're looking at external eye structures. So stand directly in front of the patient at eye level, always helpful if you're going to look at their eye structures. And look at them. Look at the position and alignment in relation to one another. Normally the eyes are parallel. Any bulging, that's called exophthalmos. That can commonly be seen in African Americans and also in people with thyroid disorders. They have crossed eyes, which is called strabismus. And that results from a neuromuscular injury or can be inherited abnormality. Look at their eyebrows, their size, extension, the texture of the hair, alignment, and movement. Can they move their eyebrows? Look at the eyelids, their position. Are they droopy? Color, condition of the surface. Are they red? Do they appear irritated? The condition and direction of their eyelashes. So if the eyelashes go in, that's an entropion, and that can cause damage to the cornea. Look at the patient's ability to open and close their eyelids and to blink. You might also see what's called ptosis, which is an abnormal droop of the eyelid over the pupil. It's usually can be caused by edema or impairment of the third cranial nerve. Ectropion is when the eyelid margin, so the end of the eyelid with the lashes, turns out. And then, as I said, entropion is where the eyelid margin turns in. So your eyelashes are actually touching your eyeball. You want to look at the lacrimal apparatus. That's their tear duct. Look for any edema, redness. Gently palpate the area, and it shouldn't be tender. The conjunctiva and sclera. So the sclera is that white area. At least it's white in light-skinned people, and darker-skinned people, it might be a pale yellow. You're going to want to actually retract the eyelid without placing any pressure on the eyeball. So use your thumb and an index finger. Conjunctivitis is redness of the conjunctiva, which is the area underneath the eyelid. And inspect, you're going to look for color, texture, presence of edema or any lesions. Corneas, you're not going to see a whole lot. You're going to inspect for clarity and texture when you shine a pen light obliquely across the entire surface. So from the side, should be shiny, transparent, and smooth. Note any details of the underlying iris, so the colored area. Then you're going to look at the pupils and the iris. So pupils, you're looking size, shape. Are they equal in size? Accommodation. So when you put your finger in front of the patient and then you move it towards their nose, and also when you shine the light, are they reactive? Okay. Pupils should be black, round, in a regular shape. They should be about 3 to 7 millimeters. The iris should be clearly visible. If you notice the pupils look cloudy, that indicates they may have cataracts. So the common term used for a normal finding with pupils is PERLA. Pupil, equal, round, react, light, accommodation. So let me see. Pupils equal, round, react to light, and okay. If you're documenting PERLA, they better be PERLA. Okay. If there's any abnormality, they are not PERLA. So make sure you're documenting accurately. When you guys get your backpacks with all your equipment in it, you will have a pen light, and that pen light actually has that pupil measurement chart that's there on the screen. Internal structures, you have to have an ophthalmoscope, and that is beyond your scope, as I mentioned. Ears. So you're looking at the structure of the ears and the acuity when you're doing an ear exam. So you're going to inspect and palpate external structures. So the auricle is the outside of the ear, the outer ear canal where you can just see, and then tympanic membrane, which you actually probably won't really do. Normally, the ear canal is about an inch long and it's curved. The middle ear, you can only see using an otoscope, and you see a picture of that right here. This is actually a normal middle ear. And you should see this right here, that shiny spot is called a cone of light. And you should see that. If you don't see that, then there's an abnormality. So the auricles, the outside of the ear, you're looking for size, shape, symmetry. Ears can be asymmetrical. Any landmarks, position, color, piercings. Are they low set or at an unusual angle, which can indicate a birth defect? You're going to palpate for texture, any tenderness, any lesions, and again, piercings or gauges. Ear canals and eardrums, you have to use the otoscope. Make sure the patient doesn't move their head while they're doing this, while you're doing it. Make sure you look for any foreign bodies initially before you put the speculum in. You might have the patient tip their head towards the opposite shoulder. So if you're looking at the right ear, they should tilt their head to the left shoulder. Insert it slightly down and forward a half an inch. Don't scrape the lining of the ear canal. Ask the patient about methods they use to clean the ear canal. They should not be using Q-tips. Warm water, a couple drops of mineral oil, and that's all they should need. Make sure you can visualize the tympanic membrane. If you can't, they may have an earwax buildup and will need flushing. So normally the tympanic membrane is translucent, shiny, and pearly gray, free from tears and breaks. And then again, if there's cerumen or earwax blocking, you're going to have to irrigate. So when we're looking at hearing acuity, is how well a patient can hear. There are 3 types of hearing loss: conduction hearing loss, sensorineural, and mixed. Conduction hearing loss interrupts sound waves as they travel from the outer ear to the cochlea of the inner ear because they're not transmitted through the outer and middle ear structures. Okay, so that's why I kind of put this one here so you can see that. So conduction loss, the sound waves get interrupted before they reach the inner part of the ear. So somewhere here, the middle ear at the bones, or in the external, in the ear canal, or even the tympanic membrane. Sensorineural loss involves actually the inner ear, so the cochlea. Sound gets through the outer and middle ear, but continued transmission is interrupted some point behind these bony ossicles, the malleolus, incus, and stapes. So somewhere back here, sound stops. Okay. And then mixed, of course, would be a combination of both. Older adults have difficulty hearing at higher frequency sounds and certain consonants. So older adults have difficulty hearing S, Z, T, and G. They may have ototoxicity, which is injury to the auditory nerve, usually caused by medication, most commonly aminoglycoside antibiotics like gentamicin. In order to check their hearing acuity, actually you do want them to remove their hearing aid. I know that sounds really odd, but you want to see their baseline. And then the whisper test. So that's when you stand behind them and you whisper something. And it can be like 3 words. And you can tell them, you can whisper, black car, cat. And then you have them repeat back to you what you said. But you're standing behind them so they can't see your lips. And you're whispering. That was a loud whisper, guys, because I wanted the mic to pick it up if you heard it. And then you have them repeat. And you do that on both sides. Okay, that way you can see if they're equal hearing. You might use a tuning fork, and the tuning fork helps you determine if it's bone conduction or air conduction. So air conduction, aminoglycosides, Veronica. So air conduction, when you're checking that, their conduction is the Rinne test. Air to bone should be a 2-to-1 ratio. So a patient should hear the sound through the air for twice as long as they hear through the bone. So what you would do is you would get the tuning fork vibrating and put it like right next to the front of their ear and have them tell you when they stop hearing it. When they stop hearing it that way, you then put the tuning fork, take it off the bone, and just put it next to their ear, a couple inches out, and have them tell you when they stop hearing it through the air. And that's what we refer to. That's the Rinne test, which is the air to bone conduction, which is 2-to-1. So air to bone. Then the Wepper is lateralization, making sure they can hear equally on both sides. Again, you'll take the tuning fork, you'll get it vibrating, and you actually put it on the top of their head. And this is to determine if the vibration stops at the same time, or the hearing stops at the same time in both ears, or does one different than the other? Okay, so I'm not sure. So bone, we're talking about the bones like of the ears. So air conduction to bone. When you vibrate the tuning fork, you're going to put it against right in front of the tragus right here. And you're going to let it vibrate. And the patient will tell you, I can't feel it anymore. Okay. So then you're going to move the tuning fork away from the ear and they can still hear it vibrating. That's air conduction. So sound will go through the bone when you place the vibrating tuning fork right here, and then through the air when you pull it off and you just listen. Okay. Yeah, it's hard to teach this part in a lecture, so I may see if I can find a video for you guys later. Generally, though, as a nurse, you're not going to do a lot of this, but you need to be aware of it. Noses and sinuses, mouth and pharynx. So the nose, you're going to inspect the external nose for their shape, the size, skin tone, color, presence of any deformities or inflammation. Is it smooth and symmetrical? For instance, if you guys ever saw my husband, your first assessment of the external structures of his nose is that it's really messed up. He has broken it a lot, and so his nose actually kind of curves to one side. The running joke is he smells around corners. You're going to assess patency of the nares, that's the openings, by occluding one at a time, not both at the same time, but one at each time, and having the patient breathe. Okay. Can they breathe? Is it more difficult through one than the other? Inspect the mucosa. So you see the picture on the top there. You're going to look actually inside and look at the mucosa, the lining, for color, any lesions, note any discharge, any swelling or evidence of bleeding. So it should normally be pink and moist. If it's pale with a clear discharge, that indicates they might have an allergy. Mucoid discharge is usually rhinitis. So if it looks kind of mucousy, and a sinus infection can result in yellow or green discharge. If you look at the inside there, you're going to look at the septum and the turbinate. So the septum is in here, and then you see right here is a turbinate. Okay, right here. So when you do the sinuses, that's actually palpation. You're going to do frontal and maxillary. So frontal is going to be right below the eyes. You're going to palpate for any tenderness or any abnormalities, air, crepitus. And then that's the maxillary. And then the frontal is just above the eyebrows. Lips, you're going to look for color, texture, hydration, contour, and any lesions. And you want to look with their lips closed. Buccal mucosa, gums, and teeth. So we're looking in the mouth. Clench the teeth and smile to observe any occlusions in their teeth. Inspect for quality of dental hygiene, position and alignment. Posterior teeth, you're going to have to use a pen light and a tongue depressor. Make sure you don't gag your patient with the tongue depressor. So you're looking for color, any dental caries that might be black or anything tartar in any extraction sites. Teeth should be smooth, white, and shiny, white-ish. Look at the gums and the mucosa, so the lining of the inside of the mouth, for color, hydration, texture, and any lesions. Um, they should be normally glistening, pink, smooth, and moist. And then look at the gums for any color, edema, retraction, bleeding, or any lesions. Tongue and the floor of the mouth, you want to inspect the tongue on all sides and the floor. Look at any deviation, tremor, or limitation of movement when the patient sticks their tongue out. So you are going to have them stick their tongue out, and you're going to look for any deviation. Look at the color, size, position, and texture, any coating on the tongue or any lesions. And then to palpate the tongue, you're actually going to use a gauze pad. When you're looking at their palate, so the upper palate, the hard and soft palates, you're going to have them extend their head back, open their mouth, and you're going to just take a look. You're looking at color, shape, texture, any extra bony prominences or any defects. A bony growth or exostosis between the two palates is common. Okay. And then look at the pharynx. Have them tilt back, open their mouth, and say, ah. Inspect their uvula, which is that little thing that hangs down, and their soft palate. Also, tonsils. If they're present, note them. If they're not present, say they're not present. Okay. All right, so let's take another little 10-minute break. Let's be back at 11:40. All right, back we go. Neck. You're going to look at the neck muscles, inspect the usual position. You're going to have the patient move their neck through their range of motion. And that looks at the sternocleidomastoid and trapezius muscles. You're going to look at the anterior triangle, which has the thyroid, trachea, carotid arteries, and anterior cervical lymph nodes. And then your posterior triangle with the posterior cervical lymph nodes. Lymph nodes, you're going to just kind of inspect for distribution and compare sides. Look for any edema, erythema, or red streaks. Make sure you're methodical to if you palpate to avoid overlooking it. You're going to use the pads of your middle 3 fingers, so your index, your middle, and your ring fingers. You're going to go occipital, so behind the head, post-auricular, just behind the ear, mastoid, pre-auricular, retropharyngeal, so just behind the pharynx, submandibular, below the jaw, submental. So you're going to try and detect a large enlargement, and note any location, size, and shape, surface characteristics, consistency. Is it mobile? Is there any tenderness or warmth? You should not feel anything if a lymph node is normal. Lymph nodes are normally not palpable. If you can palpate a lymph node, there is an abnormality there. Thyroid, you're going to look at from front and both sides of the trachea. The thyroid gland is fixed to the trachea with an isthmus overlying and 2 connecting lobes. It kind of looks like a butterfly. You're going to inspect it for masses and symmetry, any subtle fullness at the base of the neck, and then have the patient hyperextend to tighten the skin so you can better see, and then observe their swallow. And then, of course, trachea, you're going to palpate, but don't close off the trachea. No, Alicia, even if they're smaller, you should not be able to really palpate lymph nodes, because it'll be in relation to the person's size themselves. Okay, trachea. Got that. Thorax and lungs. Okay, so you're going to use data from all your body systems to kind of determine pulmonary alterations. For instance, looking at the color of the nail beds can give you an idea as to the oxygenation status. You want to listen to their lungs. The patient needs to be undressed from the waist up. And you want to begin with them sitting. So you're going to start posterior thorax, so the back. You're going to observe for any signs and symptoms. You're going to look at their shape, their symmetry. You're going to also want to look at their anterior, posterior diameter, so the amount of space between the front and back. If you notice a barrel shape, that's very common as we get older, but also in people with chronic lung disease. You're going to assess the rate and rhythm of breathing. Is it within normal? What's the normal respiratory rate range? Awesome, guys. Yes, 12 to 20 is the normal range that you will see. You also want to look at their rhythm. Are they fast, slow, shallow, deep? You might palpate their thoracic muscles and their skeleton. That's all right, Natalie. And then you can do something called a vocal or tactile fremitus. And those are sound waves that create a vibration that you can actually palpate. So if you touch their thorax area or their, where their lungs are, and you have them speak, and you don't feel vibrations, that can indicate there's a mucus buildup in the lungs or lesions or even a collapse. You'll use the palmar surface, and you just ask your patient to say 99 And you can do it in multiple areas. Go 99, 99, 99 as you're going down the thorax. Or they could say 1, 1, 1, 1. And you want to make sure if you're doing the tactile fremitus that you're doing both sides at the same time. When you auscultate, you're assessing the movement of air. Is it normal, or are there adventitious or abnormal sounds? So bronchovesicular and vesicular sounds are normally heard posteriorly. And there are 4 different types of adventitious or abnormal sounds: crackles, rhonchi, wheezes, and the pleural friction rub. If you notice an abnormality in tactile fremitus or auscultation, then you'll do vocal resonance. So you're going to actually listen when the patient says 99. And by listen, I mean you're auscultating the lungs when they say it. It should be slightly muffled, and actually certain abnormalities will make it actually sound clear. Lateral, so the side, have the patient raise their arms to improve your access. Do not access the excursion, like how much it comes out. And normal sounds should be vesicular. Abnormal sounds are crackles, rhonchi, rhonchi, wheezes, and pleural friction rub. So crackles, rhonchi, wheezes, and pleural friction rub. And then anterior, so the front, you're going to inspect the same as you did posteriorly, palpate. You're going to check for tactile fremitus, and then you're going to auscultate. So the ratio, well, Veronica, they can actually be heard throughout the lungs. So there's not one particular site that you're listening for to hear crackles or rhonchi or wheezing. It could be anywhere within the lung field. So your ratio of expiration to inspiration is a 3-2. Courtney, are you talking about the abnormal sounds? Okay, so there's actually 4. There's crackles, rhonchi, wheezes, and then pleural friction rub. So the pleura, the lining around the lungs, pleural friction rub. So again, the expiration to inspiration ratio is 3-2. And this kind of gives you an idea. Vesicular sounds are soft and breezy, lower pitch. Bronchovesicular or blowing that are medium pitched and medium intensity. And the locations are kind of here. And then bronchial sounds. So actually, crackles are most commonly found in the dependent lobes, so the lower lobes of the right and left lungs, the bases. Then you have rhonchi, which is a sonorous wheeze, usually heard over the trachea and bronchi. Wheezes, which is heard all over. And then the pleural friction rub is heard over the anterior lateral lung field, so the front and the sides. And I actually have sounds for you guys. So this is normal lung sounds, so make sure you turn up your sound. Oh, I know why it's not going, because I have these. Hang on. Sorry, guys, I was muted. So these are fine crackles, which are also known as rails. Okay, give me a second. Sorry, guys. That's kind of a bummer. So I was hoping that would work. But I definitely take these slides, guys, and go ahead and listen to those. Excuse me, they're absolutely right. Nurse Angie is awesome. Last time I heard she's pregnant, so I don't know if she had the baby yet or not. There's a lot of tricky things, and I think I had myself muted and then I unmuted, so maybe you heard. So, whoops, no, just the slide. Nope. Okay. Okay. Patient is admitted with pneumonia. When auscultating, you hear low-pitched, continuous sounds over the bronchi. These sounds are labeled as crackles, rhonchi, wheezes, or pleural rub. Excuse me. All right, so B is the correct answer. B is in boy. Rhonchi are loud, low-pitched rumbling coarse sounds heard either during inspiration or expiration. Sometimes they can be cleared by coughing, and they're caused by muscular spasms, fluid or mucus in the larger airways, new growth, or external pressure that causes turbulence. So when you do hear rhonchi, you want to ask your patient to cough and see if that clears it, because that usually indicates mucus and they just need to get it out. That's something you might commonly find in smokers. So, heart. So you want to compare your heart and your vascular findings. That's fine. I don't use Internet Explorer. Sorry. You're going to assess through the anterior thorax, so the front. The base is actually the upper part of the heart, and the apex is the tip. At the bottom, sorry, the base is the upper, the apex is the lower. Right ventricle is the most anterior part of the heart, so the right ventricle is what you're going to feel up front most. And actually, your apex touches the anterior chest wall at the fourth to fifth intercostal space midclavicular line on the left side. And that's where you're going to find your apical pulse and also the PMI, or point of maximal impact. In an infant, it's going to be a little bit higher in the third to fourth intercostal space, just to the left of the midclavicular. By the age of 7, you will be able to hear it in the same spot as an adult, so that fourth to fifth intercostal space. 4 chambers, the events happen on the left just before the right, and you have the valves. You have 2 phases, systole and diastole. Systole is when the ventricles contract and eject blood. That blood goes either into the aorta and the pulmonary artery. And that's where the mitral and tricuspid valves close. And that's what causes the first heart sound, that S1, or the lub. So systole is S1, and it's where the mitral and tricuspid valves close. Anyone remember what kind of valves the mitral and tricuspid are? No, the specific name. Atrioventricular. Yes. And then, so this is really important, guys. In systole, again, ventricles contract, blood is ejected into the aorta or the pulmonary arteries. So that's when the blood goes to your body and your lungs. And then your mitral and your tricuspid valves close, and that causes the S1 heart sound. In diastole, the ventricles relax, the atria contract, and the aortic and pulmonic valves close. And that's what causes that second heart sound, or the S2. Okay. So S1 is mitral and tricuspid closing. S2 is aortic and pulmonic valves closing. Okay. In systole, the ventricles contract. And in diastole, they relax and the atria contract. When the heart attempts to fill an already distended ventricle, so the ventricle's already been filled and it tries to fill it some more, you'll hear a third heart sound, and that's an S3. It is abnormal in adults over the age of 31. Okay, so S3 is abnormal in adults over 31, and but it can be often heard in children and young adults. So the S3 sound is considered a ventricular gallop, and it comes after the S2, so you're going to have a lub and a dub. Okay, so S1 is the closing of the mitral and tricuspid valves and ventricles contracting. blood is flowing to the aorta and pulmonary arteries. In diastole, that's S2. S2 is diastole. Ventricles relax, atria contract, and the aortic and pulmonic valves close. So then you have the S3, where you're trying to fill a ventricle. And the sound that you might hear might sound a little like Kentucky, 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 Kentucky. So you got your lub, your dub, and then an extra sound at the end. Now, S4 is a fourth heart sound, and this is often heard in older adults, so kind of the opposite of S3. It can also be heard in children and athletes too. And that makes it's the atrial gallop. So the atrias are overfilling, and you'll hear it before the S1. So it'll be Tennessee, 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 Tennessee. So before you start your exam of the heart, you want to make sure your patient's comfortable. Look for any visible pulsations, any exaggerated lifting, and palpate the apical impulse, and any source for vibrations or thrills. Where am I going to palpate the apical impulse? You're close, Natalie, but that's in children. Yep. So fourth to fifth intercostal space, mid-clavicular line. So right in the middle of your collarbone down. In women, it's pretty much where the boobs are. So that makes it a little difficult. But you can lift up the breast and see if you can palpate it. When you're auscultating, make sure your room is quiet because it can be hard to hear. Make sure you're listening to the whole cycle, the lub dub, because lub dub is one cycle. That's one heartbeat, is lub and dub together. A regular rhythm involves regular intervals between each heartbeat. Failure to beat at regular intervals is called a dysrhythmia. When you're looking at an irregular heart rhythm, you're going to compare their apical and radial pulses. So Mercedes, we're going to go more in depth into cardiac when we cover oxygenation, but then you'll also go more specifically into diseases affecting different body systems as you go through med surge. And the assessment part, the head to toe assessment is part of your skills lab. So once we can get back into the building and do some skills lab, you'll be practicing all this. I know it's really hard. Sorry, hang on. I was answering the other question. So when you want to compare, to assess a heart irregular rhythm, you're going to compare apical and radial. But you have to do those simultaneously to detect the pulse deficit. And I know I brought up pulse deficit before, and this actually kind of requires two people. The radial pulse should be a little slower than the apical pulse because the apical happens right as the heart's beating, but the radial has to wait for the wave to kind of hit. So there's going to be a slight delay. You're going to assess for extra heart sounds using the bell to hear the lower pitch sounds like your S3, your S4, gallops, clicks, and rubs. We talked about S3, the ventricular gallop, and occurring after S2. And then S4 occurs before S1. Murmurs is a sustained swishing or blowing sound heard at the beginning, middle, or end of the systolic or diastolic phase. So murmurs can happen at any time. The cause of a murmur can be increased blood flow through a valve, a normal valve, forward flow through a stenotic valve or a hardened valve, or into a dilated vessel or heart chamber, so an enlarged heart. Or it can flow backward through a valve that doesn't close. So when you detect it, you want to auscultate the different heart areas, and that's going to be, you're going to use the mnemonic apartment M. That's the mnemonic you're going to use. So follow on the screen. You can see over here, we're doing the aortic valve is on the right side of the sternum. Pulmonic is directly across from the aortic on the left. Tricuspid is just a little bit further down next to the bottom of the sternum on the left. And then your mitral, you're going to go the same where you have your apical impulse, that fourth to fifth intercostal space, midclavicular line. If you hear the swishing between S1 and S2, it is systolic. So swishing between S1, S2 is systolic. If you hear it between S2 and the next S1, that is a diastolic murmur. The location that you hear the murmur is not necessarily directly over the valve. You may also feel a thrill, and that's a continuous palpable sensation that resembles the purring of a cat. The intensity of a murmur is recorded in grades. So a grade 1 murmur is barely audible in a quiet room, like you can't really hear it. Grade 2 is quiet, but you can hear it. 3 is moderately loud. Grade 4 is loud and associated with a thrill, so you're going to see a vibration or feel a vibration. Grade 5 is very loud, and you can easily palpate the thrill. And then grade 6 is a very loud, audible with a stethoscope not in contact with the chest. Thrill is palpable and visible. So the only time I've really kind of heard what you would kind of think of as a grade 6 is basically someone who has a mechanical valve. You can sometimes hear the clicking. I actually had a patient once. I was coming in the door to his room and I heard it and I looked at him. I said, "Do you have a mechanical valve?" And he told me yes, because I could hear click, 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 click. So murmurs can also be low, medium, or high in pitch. This one was also a video. We're talking about murmurs and other heart sounds. I will actually let you guys go over this yourselves when you go back through your lecture slides, because obviously we're having some sound issue. That, and I kind of like to keep going. We'll get everything. We just may not get everything today. So no worries though. Vascular system. We're talking blood pressure is part of your assessment. The carotid arteries reflect the heart function better than peripheral. They supply oxygen to your head, neck. It's protected by the sternocleidomastoid muscles. You're going to do one at a time. And if you don't feel a pulse, there's a blockage or stenosis, which is a narrowing of the artery. This is the only site, the carotid artery is the only site to assess the quality of a pulse wave. Normally, it's a very thrusting quality. It's very strong. Excuse me, and it doesn't change with breathing. It's the most commonly auscultated pulse. And when there is stenosis and narrowing of the carotid arteries, you may hear a blowing or swishing sound that's called a bruit. B-R-U-I-T, bruit. You're going to use the bell at the lateral end of the clavicle, posterior margin of the sternocleidomastoid, and you're going to ask your patient to hold their breath. Normally, you won't hear anything. If you do hear something, that's a bruit. Jugular veins are the most accessible veins. You have internal and external jugulars. The external ones are superficial and just above the clavicle, and the internal ones are deeper and next to the carotid arteries. Excuse Excuse me. Next, you have your peripheral arteries and veins. So you're going to use the distal pads, so the furthest pads of the second and third fingers. You're going to measure all peripheral pulses for equality and symmetry. You see there's a 4-point pulse scale, 0 meaning there is no pulse, and 4 means full bounding, cannot obliterate. So what that means, cannot obliterate, if you press on the pulse, you still feel it. If you press hard, you cannot cut off the blood supply or the pulse. Sometimes you might use an ultrasound stethoscope. If the pulse is particularly difficult to palpate, a Doppler. Pulses give you an idea of tissue perfusion, so you're also going to look at skin, mucosa, nail beds. You're going to look for any cyanosis of the lips, mouth, conjunctiva, nail beds, or earlobes. So any bluing. Clubbing is a bulging of the tissues at the nail base, and it creates like a club-like effect. And that's usually due to insufficient oxygenation at the periphery. Usually it's the result of chronic lung disease. So if you notice the patient has clubbing at the base of their fingers, the tips of their fingers, they may have insufficient oxygenation. Also, make sure you're looking at their lower extremities. Ask them about any history of leg pain. Did they get leg pain with exercise that is relieved when they rest? They have constant. If you have an occlusion, it's going to be characterized by the 5 P's. So the 5 P's are pain. So pain in the leg, pallor, so pale color, pulselessness, paresthesias, which is kind of numbness or tingling, and paralysis, difficulty moving. So pain, do they have pain? Pallor, is it pale? Pulselessness, is there no pulse? Paresthesia, tingling, and then paralysis, inability to move. That is what characterizes a blocked artery or vein. Capillary refills should be less than 2 to 3 seconds, and really honestly, checking cap refill is not of very much value, but you need to know how to do it. You just pinch the fingernail bed and watch how fast the color returns. And then another thing, if a patient has chronic ulcers on their legs, they will actually have a decrease in hair. So that'll be another indicator when you're assessing hair. When you're doing peripheral veins, you're going to inspect them and palpate. You're going to look for any varicose veins, any peripheral edema, and any phlebitis or inflammation of the veins. Varicosities are superficial veins that become dilated, so enlarged, especially when the legs are dependent, so hanging down. Dependent edema around feet and ankles may be a sign of venous insufficiency or right-sided heart failure. Yes, Veronica, 5 Ps are indicators of occlusions or blockages. Yep. So dependent edema can be a sign of venous insufficiency or right-sided heart failure. Phlebitis is an inflammation, kind of occurs with trauma, infection, immobilization, prolonged insertion of an IV. For phlebitis, you're looking for any redness and tenderness and swelling over a vein site. And usually if you have unilateral edema, it's one of your most reliable findings for phlebitis. So if you have edema on one side only, that's very indicative that there may be phlebitis or an inflammation of the vein. And then the other thing you're going to look at is lymphatic tissue. You have superficial and deep nodes that drain the legs, but only 2 groups of those superficial nodes are palpable. And upper extremities, you're looking at upper epitrochlear nodes, so around the elbow. Axilla, you usually examine during the breast exam. Speaking of breast exams, so breast cancer is number 2 to lung cancer and the leading cause of death in women. So it's important that you teach women how their breasts normally look and how to feel and report changes. Used to be we pressed breast self-exams or BSEs, but those are now optional. There's limited evidence that those are beneficial. But if you are going to do a self-exam, the 4th or 7th day of your cycle after your menstrual cycle ends is the best time. Women who are at higher risk should have MRIs and mammograms every year. So what you want to do is you want to make sure you look at both breasts at the same time for size and symmetry. It's not unusual for a woman to be larger or smaller on one side. Most commonly, the breast on the side of their hand dominance is going to be smaller because they use that side more, that pectoral muscle more, so their breast is smaller. So, for instance, a right-handed person, their right breast would be smaller than their left. Okay. Make sure you look at the shape. If you notice any masses, flattening, retractions, or puckering or dimpling of the skin. If you want to bring out a retraction or any change in shape, have the patient do 3 different positions. So raising their arms above their head or pressing their hands against their hips, and then extending their arms straight ahead while sitting and leaning forward. So 3 positions for retractions or change in shape: arms above the head, pressing their hands against their hips, and extending their arms straight ahead while sitting and leaning forward. So when you inspect the breast, you're going to look at color, venous patterns, presence of any lesions, any edema or inflammation. If you need to lift up the breast to look under as necessary, make sure you tell your patient, okay, now I'm going to lift your right breast so I can look under it before you do it. Look at the nipple and areola for size, color, shape, any discharge, and the directions in which the nipples point. And you might be like, well, what? Are they inverted? Meaning do they actually poke in as opposed to the normal sticking out? Inverted nipples can be a sign of cancer. I've seen it in women when I was doing well woman exams, and I often will ask them, is this your normal? Okay, some women, it's normal for them to be slightly inverted. And so rather than going, oh my God, they might have breast cancer, and sending them for a mammogram when they don't need it, if it's a normal finding, then you don't need to worry. Make sure your nipple the areolas are equal and oval. The color in an areola can range from pink to brown depending on skin color. Normal nipples will point in symmetrical directions. They are evert and no drainage. Recent inversion, like, oh no, it just did that, usually indicates there may be an underlying growth. Teach your patient what to look for. Okay, teach them significant abnormals that they need to notify. Also check glandular tissue, supportive ligaments, and fat. When you're palpating, note the consistency. If the patient complains of a mass on one side, start on the normal side, the side that they don't have the mass. Using the pads of your 3 fingers, you can use the vertical, the circular, or the wedge technique. Make sure you get the entire breast and the tail. So the tail is this area that goes up into the axilla. So you want to make sure you're palpating up into there too. If they feel kind of lobular, like there's a lot of little lobes, that's normal. If you find an abnormal mass, you need to find out the location in relation to quadrants. So you have upper outer, upper inner, lower outer, lower inner quadrants of the breasts. The diameter, if you can measure it, shape, consistency, is it tender, is it mobile, and discreteness. So are there clear or unclear boundaries? Males also need breast exams. So you're going to inspect nipples in the areola for any nodules, edema, and ulcerations, do some palpation, and make sure their fatty tissue is soft, glandular. So you may think that, and you same technique when palpating for mass, either the vertical, circular, or wedge. You may think with men, well, really, I have had, my first clinic I worked at, I did have a male patient who was having some gynecomastia, so like breast enlargement, and he noticed an abnormality. So I sent him for a mammogram. Fortunately, it was nothing. The doctor I work with around the same time, ironically, had a male patient, who also discovered a mass. He also went for a mammogram, and they did discover he had breast cancer. So please make sure you're also doing an exam on your male patients too. Abdomen. Okay, so first you're going to look at the skin. You're inspecting for the color, any scars, venous patterns, lesions, and any striae, which is stretch marks. The umbilicus, note the position, shape, color, any signs of inflammation, discharge, or any protruding masses. Normally the umbilicus or the belly button is flat, or it can be concave. Sometimes you have an outie. And the color should be the same as the surrounding skin. You're going to look at the contour and symmetry. We're inspecting surface motion, noting any masses, bulges, or distension. Gas, a tumor, or fluid can cause distension or swelling, and skin may appear taut. Observe the contour while asking the patient to take a deep breath and hold it. This helps you look for any organs, enlarged organs, or masses. Normally, the abdomen should be smooth and symmetrical. Any enlarged organs in the upper abdominal cavity will descend below the rib cage to cause a bulge. So you're going to see a bulge below their rib cage, and you can then later perform the closer exam with palpation. But first we inspect, then you'll auscultate. Movement and pulsations. You want to look for any movement. Normally, men breathe abdominally, and women, so you're going to see their abdomen go up and down with their breathing. Women are more costally. I am an abdominal breather because in high school I did choir, and so I learned how to breathe abdominally for the maximum amount of lung expansion. So sometimes that's not always the case. If they have pain, they'll have decreased respiratory movement. You're going to look for any peristaltic movement, aortic pulsations by looking from the side. They are visible in a thin patient sometimes, but otherwise they should be no movement present. Now, this video I'm going to show you, sound is not important. I want you to actually watch the video. This is an abdominal aortic aneurysm. Guarantee you this patient is going to surgery ASAP. Maybe. Of course. No sound. I want you to watch the video, but it's not going to play. Oh, there we go. This is not him breathing. You can see it breathing there and not. See the bulging? That is the aortic aneurysm. See it pulsating right there. So very, very scary. Stop that. Stop that. Okay. Whoops. Did not want to do that. Okay, so bowel motility. Peristalsis is the movement of contents through the intestines. It's normal. Bowel sounds are audible passage of air and fluid that peristalsis creates. You're going to auscultate over the 4 quadrants. So using the belly button as a center, you're going to divide into 4 quadrants, okay? If you don't hear any sounds, then there's no peristalsis, and that's a problem. Hyperactive sounds or loud, growling sounds are often called borborygmi. That indicates increased GI motility, so the patient's probably not absorbing because everything's going out. You're also going to listen for vascular sounds. So if you hear a bruit, there's a narrowed blood vessel. Presence of a bruit can indicate an aneurysm or stenotic vessels. And you're going to use the bell to auscultate the epigastric regions in each of the 4 quadrants to listen for bruits. So that abdominal aneurysm you can see, but if you actually listened, you would hear a bruit in that area. Kidney tenderness, you actually are going to do posteriorly. And you might use direct or indirect percussion. So with the ulnar surface of a partially closed fist, you're going to percuss the costovertebral angle at the scapular line. If tender, the patient has some inflammation in the kidneys. Okay. And then aortic palpation. You're really not going to get, you can palpate around the aorta, so where you see in that aneurysm, sometimes you may or may not see it. So when conducting an abdominal assessment, the first skill a nurse puts to use is A, auscultation, B, inspection, C, palpation, or D, percussion. Right. So it is inspection. You're going to inspect first. Good. What is the next step in doing an abdominal exam? Who can tell me which one would be next? Yes. It's going to be auscultation. Good job, guys. So now you've inspected, you've auscultated. Now what? Good. And then, of course, finally will be percussion. Okay, so we still have a little bit to go. I'm not going to keep pushing it. We can finish this up on Thursday. I had to think about that. Okay, so that because there's not a whole lot left, more the genitalia and some cognitive. So let me, whoops, speaking of, there it is. There we go. All right. It is a lot to retain, and I'll be honest, and I'm sure you guys are going to be frustrated a little bit because you're not able to actually practice these. So I'm teaching you this stuff in theory and telling you how to do it, but you're not necessarily getting to do it, and so it's really can be difficult, and I appreciate that. So I'm looking forward to Skills Lab, and when we get into Skills Lab, don't worry, we'll be reviewing all these things, okay? Excuse me. So that RN nursing, definitely highly recommend going to YouTube and going through her videos. There's be some great videos about how to do a head to toe assessment. And I actually myself, I'll go look up one and see if I can find one that's good for you guys. So you can kind of see it. And that way, maybe you can even start practicing at home. The reason I want to do it is that she is really good. I want to make sure that you get a right one and don't learn any bad habits. So anyone have any questions, concerns, comments before we end today? I think this class, there's quite a few of you who are in the medical field, and you may have seen. If you haven't and you work, ask if you can stand in. Yes, Angelica, there is a stethoscope. So you do not need to purchase one. Yes, Courtney, I am going to upload this again. At this point, Andrea, I'm giving a little leeway, but honestly, because I'm gonna keep this, let's say this to keep it simple. So Kaplan was due today by the beginning of class. If you haven't remediated by the time it's due, then you will not get points for remediation. However, even if that happens, I really, really highly recommend you do remediate so you review missed points. The thing is, I'm going to look at them on a week by week basis to give you your scores. I'm not waiting till the end to go through, that would be 290 Kaplans. So each week I will be going into Kaplan to see who's done them and who hasn't. So don't worry though, I don't take off a whole lot of points. Hayes, I'd prefer you do not work ahead because I usually go by week. So I will go starting. So for the next Kaplan, I would start from today through next Tuesday, and then I might miss something. Correct, Mercedes. There's nothing for you to do through Canvas. You just go through Kaplan, and I actually can even download scores if I needed to provide for like accreditation and stuff. So. Not exactly, Jillian. There are only 10 Kaplans that you need to do. And it's not every week. So look at your syllabus and your modules to see what's due. And it doesn't matter which one you do. Like I said, I recommended that you take one that might be relating to um, the what the material taught. So but that's completely up to you guys. Liara, I know I literally was emailing her during one of our breaks. So yes, you in this instance, I am giving you a little leeway because we were having issues for you with Kaplan. Well, Courtney, you can kind of go out and one thing that would be great with that is I won't take off points if you do it a second time. So say you did one now and you're like, oh, that one was way more than I could do. And you remediate. So you got points for that. And then maybe you're like at towards the end, like your last Kaplan, and you're like, I'm gonna try that one again and see how much I've learned. You can redo that one again and get a better score, and then that would be totally cool with me. Some of the ones it's hard to tell you which ones to do and not do because it's just kind of a learning process, and some of it you'll know, some of it you don't. You might not want to do any dosage calculations right off the bat. You want to make sure that you're doing ones that um, you're doing those like later after we get through more of the math. Yeah, and with picking which ones you should be doing, that's why I recommend the material. I don't know where you heard that, Shanae, but that is completely inaccurate. I don't know what they're talking about. At the end of each class, there's a subject matter exam, which is worth 50 points. At least for this class. I think that's the same everywhere else. There's also an NCLEX type class toward at the last. But yeah, I don't know anything about that. Oh, and the MAPE, that still, I mean, if you don't, you do have 3 attempts of the MAPE, and then if you don't pass it that time, you remediate and you take